is to be the most trusted healthcare partner and preferred destination in Nigeria and the West African region, transforming the quality of healthcare and positively impacting lives across the region.
At Evercare Hospital Lekki, we are well positioned to address the gaps that exist in the Nigerian healthcare sector, and we aim to be at the forefront of advanced treatments in major clinical specialties. Our focus specialties are mother and child services, cardiac sciences, neurosciences, orthopedics, critical care and emergency medicine, amongst a range of other specialties. We have engaged a team of highly skilled and experienced full-time visiting consultants across subspecialties of medicine, surgery, pediatrics, obstetrics, and gynecology. A collaborative team approach to care will be promoted, continuously monitoring patient-reported outcome measures for optimal patient satisfaction and quality improvement.
As a purpose-built multi-specialty tertiary care hospital, our patients will receive comprehensive care that is efficient and thorough. Our infrastructure systems and services are designed to assist our physicians to deliver world-class services to patients.
At Evercare Hospital Lekki, we believe that every individual has the right to respectful and compassionate care as a patient. And we have introduced a framework for patient experience, encouraging each caregiver to treat every patient as they would their own family. Our caregivers are passionate about providing patient-focused care, and this reflects in their attitude to the patient's overall experience at the hospital. We have been strategic in attracting the best talent locally and complementing their skill set with international experts to ensure a highly skilled, well-rounded, and diverse team.
Technology is critical to delivering high standards of healthcare. Evercare leverages advanced technology and state-of-the-art equipment to ensure desired clinical outcomes are achieved.
We are fully equipped and technologically advanced to cater for high-risk pregnancies and even the most fragile babies. An entire floor of the hospital has been dedicated to serving women and children.
Evercare Hospital has been designed to promote seamless patient flow and positive patient experience by positioning our entire daycare services, physiotherapy, chemotherapy, endoscopy, and dialysis on one floor. Our endoscopy unit is equipped to investigate and treat the full range of pediatric and adult gastrointestinal diseases, including advanced endoscopic procedures.
At Evercare Hospital, we have a multidisciplinary team of specialists to treat a wide range of cancers, supported by friendly and relaxing chemotherapy units for patients and relatives.
Evercare Hospital Dialysis Unit is managed by a team of highly experienced dialysis nurses, technicians, and nephrologists. The unit provides a welcoming, spacious atmosphere with individual entertainment units for patients to help pass the time. Affordable quality service is provided by strict adherence to guidelines and standard operating procedures.
The physiotherapy unit at Evercare Hospital provides the most comprehensive rehabilitation program for patients, particularly those with stroke, nerve injuries, and pre- and post-surgery, giving them better quality of life.
Evercare Hospital has managed to attract highly talented group of nurses practicing in a dynamic environment to provide empathetic care. Our promise is to provide high-quality nursing care in a safe and comfortable environment.
We believe every individual has the right to respectful and compassionate care as a patient. And with the largest critical bed units in a private setting in Nigeria, we are well prepared to address the critical care needs of Nigerians.
Our in-house physicians, partnerships with Nigerian doctors in the diaspora, and doctors from Evercare Group will ensure that we have the capacity to provide treatments that many Nigerians seek abroad.
Quality is at the core of Evercare Hospital Lekki's healthcare mission. A robust clinical governance process has been implemented to ensure continuous quality improvement and the adherence to international standards for ethics and compliance. At Evercare, we will constantly innovate to ensure delivery of best-in-class standards of patient safety, clinical excellence, and outstanding clinical outcomes, with an unparalleled patient experience. With our dynamic and passionate team of caregivers, we look forward to embarking on our journey to transforming lives.
Good morning, ladies and gentlemen. Thank you all so much for
Welcome
being
to
here.
Evercare Hospital, Lekki.
Good morning, ladies and gentlemen. Thank you so much for being here. You are welcome to the inaugural Evercare Surgical Colloquium 2024. We are really glad to have you here. We will not take so much of our time to kickstart and get the ball rolling. I would just have the honor to welcome Dr. Ayo Shonibare, our Chief Medical Officer here at Evercare Hospital, Lekki, to come and give us the opening remarks. Can we please give him a round of applause?
Morning, distinguished ladies and gentlemen. We need to keep to time because one of our speakers is actually going to speak from Atlanta, US, and I think it's about 4:35 a.m. So we're not going to be able to delay. So unfortunately, we'll not be able to wait for people to come into the room. So we'll get started. I'd like to actually welcome you to this occasion. This is the first that we're holding. It's a surgical colloquium, and you will see the value during the course of the day. It's going to be quite exciting. We've been preparing this for quite some time, and I take this opportunity to thank all the people that put this together, business and marketing team, Chioma, Soyib, Eval, and the rest of the people in the room who have done a lot of work to put this together. Basically, this is to showcase what we've achieved on the surgical side. It's going to be focusing mainly on cardiothoracic surgery and minimal access surgery. We've got some very exciting speakers. We have the big surgical giants. One of them is in the room, Dr. Jimmy Coker, who is actually kindly agreed to do this for us. So we really appreciate and thank him for this. We also have another big surgical giant, Dr. Sanusi, who will be speaking after this, presenting from the US. He has made significant contributions to cardiothoracic surgery development at Evercare. He'll be coming back to Nigeria at some point, and we hope to see him soon. And then we've got our own smaller giants at Evercare, Ifedayo, Arua, Akinola, and Arinze. Arinze is not here yet. So they will be presenting their work, some of it very impressive that you get to see. So I just have a few slides, but I must finish at 10 past. So I'm going to run through the slides so that Dr. Sanusi, there's no delay whatsoever. So basically, I think you've seen the video of the hospital. We're really here to transform healthcare. Healthcare is changing in Nigeria. A lot of advanced procedures are actually taking place, and we'll continue to work on outcomes, quality, to make sure that we attain international standards. Mission, vision, basically, like I said, we're all about patient-centric care. We'll continue to improve to attain this mission of improving healthcare generally to the community. Those are pillars: quality, operational excellence, people, and then impact. So at Evercare, of course, you've seen that video with all the facilities in the room. In terms of the surgical specialties, Evercare is just a little over 3 years old, and we've actually managed to incorporate advanced surgical specialties, and we've brought in a lot of visiting, highly skilled, talented senior clinicians to do a lot of this work. So basically, I mean, those are just a summary of the achievements to date in those specialties. Cardiothoracic surgery, from pediatric cardiothoracic to adult cardiothoracic. Pediatric surgery, Arua is doing a lot of amazing work, which you'll get to see later on. General surgery is the same. Arinzechukwu is also moving up. And like I said, we also have Sapphire, who are visiting consultants who have been doing some incredible work. And Dr. Koka will tell you all about that in his own presentation. Urology, of course, Adejare is also doing some good work. Retrograde intrarenal surgery is interested in stone management, and you'll see quite a lot of what he's doing during his presentation. And gynaecology, again, minimal access. Like I said, the focus will be on minimal access and cardiothoracic surgery. Hopefully, subsequent colloquiums will bring other surgical specialties and advancements we'll try and do this every year. So basically, why surgical colloquium? People may ask, why are we doing this? And as you can see, in terms of networking, we're expecting, hopefully, a lot of younger surgeons to come later during the day, and they'll be learning a lot. They'll be meeting new people, networking, friends, and learning, and they'll be able to apply a lot of what they learn to their own practice, all to improve patient outcomes. And research is also collaboration, so people in collaborating, and then you can also have second opinion. When you meet a senior, you get contact. That is very useful for a young surgeon to have someone that they can always go to when they have challenges. So this is going to be a regular exercise, and we think it's actually going to impact the younger surgeons and doctors, and even aspiration of people who are not sure about their specialties. When they interact, when they see this, they may actually decide to go into surgery as a specialty. Well, I'm not going to dwell much on this, only just to say that in terms of Nigeria, where we started with Babalawos way back then, but now we're doing, in fact, people in the room may not know, we're now doing minimal, this is not, was in Nigeria, minimal access cardiac surgery. The first set took place last week at Tri-State. So this is just to show the advancement and where Nigeria is getting to. So like Dr. Koka will be talking a lot about evolution of minimal access in his presentation, so I won't dwell on this. This is, again, just to show that this is taking place in both public hospitals and private hospitals in terms of advancement and minimal access. I'm sure, well, interestingly, our own young giants, Ifedayo, Arua, and Arinzechukwu, all three came from Ife. Now there's somebody in Ife, Adejare, I believe, who has been doing minimal access surgery for quite some time. So being able to achieve this in a public hospital is a big deal. A lot of hospitals are now coming up, and we're going to see a lot of advancement in Nigeria. This is just to show you, in terms of open heart surgery, even the most complex, okay, I got 3 minutes left. The most complex of procedures, they're being done. Over, I think as of last count, 1,647 cases of open heart surgery. So these things can be done. Again, kidney transplantation that started year 2000. Again, about 1,500 cases have been done to date, about 16 centers. So it's quite interesting what's been going on. That's a list of the centers doing this work. So, well, with all the challenges in Nigeria, we'll still continue to move ahead. There's a lot of work to be done. We don't have robotic surgery and all other minimal access procedures, but those things are coming. I'm almost certain that robotics will be introduced very soon. Well, I will not go through this in the interest of time. In terms of advancements in global future trends, you'll be amazed at what is being done today from natural orifice transluminal surgery, which means you do surgery and there's no single scar. So you go through the mouth, go through the stomach, do the abdominal surgery because you haven't done any skin scar. That's been done. Surgery is being done through the vagina, so taking gallbladders out. That's been done. So there's no scar. This is what the patients are asking for, and we will also be moving in that direction at some point. AI is coming in, advanced technology, imaging. You can superimpose your image during surgery so you know exactly where you're going, no errors. And of course, robotics with precision surgery. A friend of mine just called me yesterday. He had robotic transplant in UAE. And he had it done 2 days ago. He's going to be out of hospital maybe in about 2-3 days. So this is the advancement in surgery. It will come to Nigeria, and we're all excited that this is taking place. And some of the people in the room are the people that will be moving this ahead. So exciting times. Thank you very much.
Can we please appreciate Dr. Ayo one more time? Thank you so much, sir. Okay, we are currently trying to connect with Dr. Sanusi. He's already online. Are we good to go with Dr. Sanusi? Well, we know how it goes with virtual connections. There's always one delay or the other, so please let's be patient. While we're doing that, you can take the moment to look to the person to your left, to your right, and get acquainted with them. And that's part of why we're here, is to also transfer knowledge. Yes, I like the energy I'm seeing in the room. So we get to know the person beside you, find out something why they're here. They could be the next big thing in the surgical world. You never know, so please get acquainted with them. We're also very excited to have in our presence Dr. Olujimi, who is going to be our esteemed keynote speaker, just as Dr. Ayo had said much earlier. IT team, are we good to go? Not yet. Anyways, something that they've not mentioned is that we also have some esteemed guests coming from other schools. We have our students who are coming from LASUS. And today is one out of the 3 days that we've planned for the Evercare Surgical Colloquium. For day 2, we're going to be having a dry workshop, which will be taking place at LUTH at 9 a.m. And it's going to be a really good opportunity for aspiring surgeons to learn under a very brilliant mind. I always wonder how he does what he does, and I'm talking about Dr. Arua, especially when he tells us how he works on a kid or a baby who is 24-hour-old. How do you even have the courage to work on such tiny, tiny human beings and do such brilliant and excellent work? So these are the kind of brilliant minds and expertise that our colleagues will be learning at the dry lab workshop tomorrow at LUTH by 9 a.m. And following that, for day 3, we would have the live surgery. It's going to be featuring 2 surgeries taking place at the Evercare Hospital, Lekki. You can attend in person right there at the hospital and get to see firsthand, real time, as the surgery is taking place, or you can join in online. We would also share the links with you to join in. Even more so, For every doctor, every consultant who is present today, they get to receive the CME points, 10 CME points, and I think that's brilliant as well. We would also like to use this opportunity to appreciate every one of our supports and every one of our sponsors for this event. They have been so gracious to join us on this journey, and with no particular order on the list, we would like to appreciate the good people of Medvac Pharmaceutical Limited. They've been really wonderful supporting this event. Can we please appreciate them? Medvac Pharmaceutical Limited. And we'd also like to appreciate Africa Renaissance. They've also been a good Africa Reinsurance. Sorry, I missed that up. Africa Insurance. They've also been a good support of this event. I think I've just got notified that Dr. Sanusi has connected. IT, can you please confirm? Okay. Let me just go through the list of our other sponsors. We also have good support coming from Worldwide Healthcare, and they have a stand right outside this hall in case you want to get to know more about them. And coming up on that list is Tanit Medical. We also have Tanit. They've been a wonderful support towards this event. And of course, last but not the least is Layer 3. Layer 3 have also been really phenomenal. And of course, this event will not be happening without our esteemed guests who are here joining us from all over the world, online, and of course, right here inside the hall. We'd also like to give a special thanks to the board and to the management of Evercare Hospital Lekki. Thank you so much for the support from day one when this idea was conceived. Can we please appreciate our board and management when they approved of this idea and gave us every necessary resource and support to run and actualize this. Thank you all so much. We also have men and women of the press who are present here as well. They would also do well to get this to the necessary places where it needs to be. Are we good to go? Almost there. Okay, almost there. You know, we actually checked the weather report before fixing this date. Some of you may not know, but it wasn't supposed to hold today. It was supposed to be on the 1st of August, which we had communicated, but we had some issues. However, the weather is also holding back some of our guests. Nonetheless, we're still optimistic that they would soldier on and make their way into the hall. Okay. I think we're good now. Not yet. We're very particular about this particular speaker because he's really doing us a huge one with the time difference. He's streaming in live from the United States of America. And if you check your time right now, you would know that he should probably be in between, his sheets, sleeping. But he's showing up here this morning to do this for us. That's how much passion and dedication that he brings to his work. And it's not something that we take for granted at all. Okay, IT, how are we doing? All right, whilst we wait for them, maybe we can just get to learn from some of our guests who have just walked in. This is Evercare, Evercare Surgical Colloquium 2024. We will just play a very short video that would introduce ourselves and let you know about who we are and our expertise. Yes, we can hear you, sir. Yes, please, it is. Please speak. We can hear you, Dr. Sanusi. You can please proceed. Okay, Sanusi, please, you can proceed. We can hear you.
the heart comes from
Yes, it's much better. We can see your slides now.
Okay. Can you still, are my slides moving now?
The slides, the slides are moving, yes.
Okay. All right. Sorry about that. Let me just mute this other. Okay. So so you can see my pre-op conference slides now. Hello? Can you see my slides?
Yes, we can hear you.
And you can see my, okay. All right, so I was talking about the arterial switch surgery patients. So after if the surgery isn't done within the first week or two of life, the ventricle really starts to fail because the heart gets lazy. It's used to the left side of the heart supposed to send blood to the body, is just used to sending blood a very short distance to the heart, and after a while it's not strong enough to send blood to the body again. So surgery really should be done early. But this child came to us at 7 weeks. So with this presentation, we had to decide whether it was worth doing the surgery. But fortunately, on echocardiogram, the left ventricle looked like it was still kind of round and globular, meaning it's pressurized and probably able to function, as opposed to the becoming very thin and the shape of a pancake, which portends post-op surgery when surgery has been done. I don't know if you'll see my slides if I go back onto my onto the slideshow.
We can see your slides, sir.
Are my slides moving now?
Well, it's still on full screen. Can you go to presentation mode? It's at the bottom, right before your volume icon.
The slides?
We can see your slides, sir.
Okay.
There's no picture, it's just the text.
Can you see my slides now?
Yes, sir, we can see your slides.
Hello?
Yes, sir, we can see your slides.
Thank you very much. So, usually with the transposition of the great arteries, it's impossible to get blood to the body, to get oxygenated blood to the body. So, but fortunately, the baby was still alive at 7 weeks, and that was because he had another congenital anomaly called PDA, which is really very abnormal, but in this case, kind of saved the baby's life. And so the child actually had surgery done. We had to do the procedure called an arterial switch, which is switching the arteries that leave the heart from to the correct places and switching the blood supply with it. So this the child had a tough time in the ICU post-op, but eventually was discharged and went back home to Abuja. This is the post-op period was because the heart initially had to recover. The left ventricle had been doing the wrong work for
a period of 7 weeks. So it's like having to lift weights again to do what it was really designed by God to do. I want to show you some of the slides from this procedure that I hope it will play. So this is the heart. You know, this at surgery. These are the cannulae that take blood to and from the patient to a machine called the bypass machine, so that we can stop the heart and actually work on it while this machine acts as an artificial heart and lung. This is the blood supply to the heart that we'll call it harvesting. So we've removed the abnormal blood vessel, and we have separated it from the heart. And this is the blood supply to the heart, which we have to take. These are only a couple of millimeters in width. So this is 1.5 millimeters, 1.5 millimeters, and you have to take it off the heart. And this is when we've taken them off the heart. This is the valve that comes out of the heart. This is the aortic valve that comes out of the heart. So we have to create a new aortic valve on the other side of the heart. So this is the new one that is being, this is what was a pulmonary valve. We are making it an aortic valve. We've sewn the coronaries onto this here, and we're sewing the other coronary artery. There are 2 coronary arteries. We're sewing it onto the pulmonary valve, which is going to be our new aortic valve, and the old aortic valve is going to become the pulmonary valve by the time we're done. So there's a procedure known as the Lecomte procedure, which is part of this surgery where we switch the arteries from one side to another. I'll play this video about hopefully we'll play the Lecomte. So that's the aorta, which is being switched and above it with the blue ribbon is the pulmonary artery. So we've switched the aorta and the pulmonary artery, and now all that is left to do is to sew them back to their new positions. I know this can be difficult to conceptualize, and I do hope that my slides are being seen. Sorry if I can't get them on the slides mode. They don't seem to move on the slides mode. So another interesting case that we did was a case of an aortic dissection that also came in from Abuja. It was a 42-year-old male that had gone to Abuja for kidney transplant, and while waiting for his surgery, he developed chest pain. And after some workup, they discovered that he had a condition known as an ascending aortic dissection, which is a type 1 dissection. Now, this is a very morbid situation with high mortality. If this condition is not treated, there is for every hour for the first 2 days, there's 1% of the patient dies because the aorta ruptures, or there's a condition called cardiac tamponade, where blood fills the sac around the heart and the heart cannot beat again. So also, even with surgery, the tissues are so friable that mortality for this surgery around the world, even with surgery done, is 20 to 40% of patients that have surgery don't make it. The patient actually was transferred to Evercare that day and had successful repair of his aorta, and has since gone on and had his renal transplant when I checked with the transplant team at the hospital in Abuja. So I don't have slides for this patient, but the next patient is a bit similar. Also came in acutely distressed. That's was a young man, undergraduate that was admitted from Eastern Nigeria in cardiogenic shock. He has described as a New York Heart Association of class 4, which is the worst class of in this classification of heart failure. He could hardly lie down flat because his lungs get flooded with blood, and he cannot breathe when he lies down flat. He had been rejected from other hospitals around the country, and even though he could afford to travel out of Nigeria, he was too sick to get on a plane. I think he came he was actually driven by ambulance from Eastern Nigeria. He couldn't go on high altitude. They arrived at Evercare Hospital about 10 p.m. that night, and his CT scan and echo, which I had sent to me beforehand, had a 9-centimeter aortic aneurysm with severe aortic mitral and tricuspid regurgitation. Now, the normal size of the aorta is less than 4 centimeters, and usually surgery is usually about 3 centimeters actually is the normal size of the ascending aorta, and surgery is recommended when it's up to 5 centimeters. So usually most places around the world never get to see a 9-centimeter aortic aneurysm. And this, because the aorta had gotten so big, it was also acutely dissected, and that's why this young man was so sick. He had fluid within his pericardial cavity, and his heart function was less than 35%. I think I'm being, normally it should be about 65 and above percent. I mean, every time the heart squeezes, at least 65% of the blood within it should be ejected out into the aorta. All these valves were leaking. So the team was gotten together. He was taken urgently to surgery the next morning. He had an aortic root replacement or a Bentall procedure. He had repair of the aortic dissection, which was of the ascending aorta. We repaired his mitral valve and also repaired his tricuspid valve. He was very sick and spent about a month in the ICU the whole of the Christmas period last year. What kept him in the ICU was allowed his heart to recover. He had an intra-aortic balloon pump in place, which helps to support, which is like an extra heart support for the heart. And so while he had this in place, the heart was able to recover, and eventually we were able to get him off the ventilator. He was in renal failure and was dialyzed, and eventually was discharged home very early 2024. He spent the whole of December 2023 in the ICU. So the importance of this case is that it's not just doing the surgery, but also the support that because some patients are very sick and the heart doesn't recover immediately the day you do the surgery. The heart has been abused and traumatized from being so sick. So the muscles are weak and they just have to, just like going to rehab, it has to go through a period of rehab. And this patient was able to have this done at Evercare because of the facilities. So there was a balloon pump there, and there's a very experienced intensive care team, and there's dialysis that can be done at the bedside in the ICU. So this patient is too sick to go down in a regular hospital to dialysis center. So now not every ICU has dialysis at the bedside, because it's for what it takes to have it done, all the machinery and the quality of water that's needed for that dialysis at the bedside. And so this is kind of difficult to believe. This is this patient's chest when we opened up at surgery. Now, this is the heart. This is the aorta. It's filling the whole chest, and it's red and very angry. So this is what I mean by an aortic dissection. You can get a feeling that it's very thin. It's about to tear completely and rupture into the patient's chest. This size of aneurysm is hardly seen. It's usually seen in a place like Nigeria because of neglect and lack of diagnosis. Most places would have taken care of this aneurysm when it's about half of this size. This is the patient we're talking about. This is the aorta, close-up of the aorta. This is the blood taking. This is bypass cannula here. Now, the dissection means that there is a tear within the wall of the aorta. You see, this is a blood clot. I hope you can see my cursor. I'm really hopeful about that. This is a blood clot within the wall of the aorta. This is the inner wall. This is the outer wall. It's dissected. The layers have been dissected out. This dissection actually extended down towards the patient's pericardium, and it's very thin and about to rupture out into the free mediastinum. I think this patient actually came just at the nick of time, to have survived his surgery. And I think another case that I would present is something else that is not done in other centers of the country, which is the DORV, is a double outlet right ventricle. So this is an 8-month-old girl that was referred by the pediatric cardiologist, who presented in heart failure because of congenital double outlet right ventricle. So that means both vessels, the aorta and the pulmonary artery, the great vessels leaving her heart, exit from the same ventricle, the right ventricle. And the only way she could stay alive is because she had another congenital defect known as a VSD. So that's the only way blood could mix from the lung and get to the rest of the body. So she also had been treated for heart failure, and the blood had to be rerouted back within the heart from the VSD to the, so blood come from the left heart to the aorta, and this is done by implanting a baffle within the heart. This is a picture of her surgery, and this is I think this video shows the VSD in the heart. This is me showing the VSD. That's the hole in the heart of this patient. That's where that forceps is in. And then we had to look for the aorta, which is above, high above where someone is retracting. So there's a VSD had to be routed up that's the VSD, has to be routed up into the aorta, with a baffle. We call it baffling, so that blood can go back to the left side from the left side of the heart to the aorta, which is the artery that takes blood out of the heart to the body, that takes oxygenated blood to the body. So this has to be carefully done, because of if it's not well done, then there is enough blood doesn't get out to the body, and the heart would be under a lot of pressure and fail. So this get to my next slide. Okay, so this is after the baffle. This is videos taken after the baffle had been completed. We usually use for this, you have to make a baffle made of Dacron or graft. We call it graft material, which is the same like an artificial blood vessel within the heart. So this is a video of if I can get it to play. Yeah, so this is a video of the baffle that we made. So that's the artificial graft material. It's like a pathway tunnel, like an underground tunnel that takes blood from that VSD and baffles it all the way to the aorta. So this is after we have placed the baffle. The blood has gone through. Blood now flows from the left side of the heart, which is behind. You can't really, obviously the heart is stopped now. and these are retractors within the heart. So you can see this is looking inside the heart. This is the atrium, and the tricuspid valve is right here, and this is the ventricle. So this baffle is within the right ventricle, taking blood from that VSD, which I showed earlier, to the aortic valve, which is up here. So all the VSD and aortic valve are behind the baffle now. Okay, so we also have done some good vascular work at Evercare. Some of the work has been together with a vascular surgeon that I partner with, coming out of the United States, especially for the vascular work that's done in the cath lab. That's endovascular, but a lot of our practice has done a lot of open vascular cases at Evercare. So we've done a lot of dialysis access cases. I didn't put all the dialysis cases on my list because they're quite a bit, but a lot of dialysis access cases and surgery for peripheral vascular disease. An interesting one was patient that had a May-Turner syndrome, which is essentially this patient presented with complete occlusion of the leg of the femoral vein, which was revascularized with a stent in the cath lab. Another interesting one is a femoral to anterior artery bypass that we did on the patient that came with an ischemic foot, 72-year-old lady that came to us because one of the nurses at Evercare was her relative, and they had been offering her amputation at another hospital, but so she tried us out, and a CT scan showed that she had severe peripheral vascular disease, femoral and popliteal artery. So this shows we did a femoral anterior tibial artery bypass for her with our own reverse saphenous vein graft, and we were able to save most of the foot. I have pictures of her here. This is her on the table. This is after we're done the bypass. We're taking blood from femoral artery. Now, unfortunately, the plaster is on here. This is where we brought the blood down to, where there's a little stain here. And after we're done that surgery, this foot she had a whole 4-foot gangrene, which was this toes were already gangrenous, meaning they were already dead. Really, there's nothing anybody could do about them. But after we did the bypass and we did a Doppler, we found out that there was blood coming to the foot, but the blood would only make her sicker if we don't get rid of this dead 4-foot. So with the help of the vascular surgeon, we actually took out, sorry for the graphic images, about all the part that was not viable on the foot. And this is her a few months later with after there was good blood supply to the foot granulated. We had used the wound vac system to allow granulation, and then we did skin grafting to the foot, and she's ambulating today. We did quite a bit of thoracic work. We do quite a bit of thoracic work as well, and so at Evercare Hospital. Important thing is that the VAT surgery has been offered there. VAT, video assisted thoracic surgery, meaning we don't have to make big incisions. We've done lobectomies, PDA ligation, and together with Dr. Arua, metastectomy and decortications. These are some of my team members, not everybody, but the OR nurse, the technician, ICU, pediatric ICU nurse, and my humble self, and some of the team leaders here. I'm sure you can all recognize who the team leader is here. Not everybody here is an Evercare team. We have a couple of visiting surgeons from Ife and from LUTH. But my partners, shout out to Dr. Daudu, Dr. Ribayo, Dr. Shokumbi is our pediatric cardiologist, and our excellent perfusionist, Rani. So I think I'll stop here. Thank you. I hope you saw my slides properly and you could hear me properly. Thank you.
Thank you so much, Dr. Sanusi. Thank you. Thank you so much, Dr. Sanusi. We appreciate you. Thank you. Can we please once again appreciate Dr. Sanusi? Thank you. And also to your yourselves.
Yes, I can't hear again.
All right, Sanusi. Thank you so much, sir. Okay, so that was very enlightening, very, very insightful. I'm no surgeon, I'm no medical doctor, but I'm able to appreciate when such knowledge, such medical brilliance are put into place to increase patient success and to increase patients' wellness. So we really appreciate what it is that Dr. Sanusi and the team at Evercare Hospital Lekki are doing. We'll move on to the next steps, and before we do that, we'd also like to recognize some very important persons here in our midst. We have a representative from the Ministry of Health, Lagos State, Mrs. Shola Aketi, here with us. Can we please acknowledge and appreciate her? Thank you so much for being here with us, ma'am. Thank you. And of course, to our viewers online on YouTube, we can't see you, but we know you can see us. So thank you so, so much to everyone who is streaming from YouTube. Thank you for being here. You can leave your questions. We have a moderator who is there with you. The questions will be taken note of and directed at the surgeons towards the end of the event. We also would share the link of the agenda just so that you can also follow what it is that we're doing real time right here. We'll move on to our next speaker. He is a quintessential gentleman. He is our esteemed speaker of today's event. I'll briefly read out his profile, which you can also follow through on the screen. Dr. Olujimi Koka is the president of the Laparoscopic Surgery Society of Nigeria. He is also on the advisory board of the IRCAD Africa and an instructor at the Advanced Laparoscopic General Surgery courses. He is also an intercollegiate fellow of the Royal College of Surgeons of England and a graduate of the Advanced Management Program at INCH, European Institute of Business in France. And he's currently the managing partner and CEO of Sapphire Surgical Center and CEO of Habervit Healthcare Limited. He is a renowned consultant, laparoscopic and general surgeon. He's a mentor to many. He is such a wonderful, wonderful leader and a brilliant gift that we have in the surgical sector. Without further ado, ladies and gentlemen, can we please welcome Dr. Olujimi Koka.
Good morning, everybody. Nice to be here. I'd like to say a special thank you to the management of Evercare Hospitals for inviting me to give this address, particularly to Dr. Shonibare. He and I have known each other for well over 30 years and have been in the struggle and vanguard of improving healthcare in Nigeria. And I continue to admire his tenacity and the work he does. And same for everybody. So, yes, well deserved, well deserved. Can I have the slides, please? Oh, okay. Oh, great. So my talk today is on evolution of laparoscopic general surgery in Nigeria. And I've split the talk into two parts. The first part looks at the journey so far, and then the second part talks about the recent advances in general surgery and also the importance of artificial intelligence in what we're doing in general surgery. So the gynecologists were the ones that started laparoscopic surgery in Nigeria, and I could remember as a medical student and house officer in UCH, seeing the gynecologist with the one eye looking in holes that nobody else could see. And in the early 2000s, the general surgeons then adopted laparoscopic surgery in Nigeria. Although I was just reflecting, I did my first laparoscopic cholecystectomy in 1993. So that's well over 30 years ago. I was still practicing in the UK then. And the problem we have here is that we don't have enough people doing laparoscopic surgery consistently. And I'll come to that later. Because we have this problem that with laparoscopic skills, as I will demonstrate, the numbers do matter. The more you do, the better you get at it. And not just with live surgery, even using simulators, equally important. And if one isn't doing enough or the resources are not there, then the caseload will not be sufficient to acquire the skills that gets one up the learning curve. The current experience in Nigeria is still tough, very tough, even tougher now than it was, because everything is in dollars. The startup equipment is quite capital intensive, and everything that one needs to purchase is in dollars. So the cost of startup is a lot. The consumables are also majorly reusable, although one can look at mitigating that by using reusable consumables. Then biomedic engineering maintenance remains a challenge. There are few training opportunities. We've tried to come together as a group to try and support each other, mentor and train the young ones. And I'll say a word or two about LASSON and BMSN. And whilst we are struggling here, the world is moving on. And we still continue to play catch-up. And I don't know how long that is going to remain. In terms of the pioneers of laparoscopic surgery, in general surgery in Nigeria, really a lot of credit needs to go to two individuals. The first on the left is John Ojukwu, who some of you would know. John returned from the States, I think he was in Atlanta, and came back to Nigeria in 2004-05 to set up the Advanced Video Laparoscopic Surgery Center in Lekki, and he was in private practice. And he continued to do his best. But really, the king, the supremo, the person I'm most proud of, is a young man who is quite dear to my heart. On the left, Wale Adisa. Interestingly, Dr. Shoni Bare talked about him. And I know that most of your surgeons are his proteges. And Wale and I have known each other now going 20 years, and he's just done amazing work at Ife with limited resources, in spite of, rather than because of, the support he gets. And he continues to do amazing work. That's us with the founder of ERCAD, the mecca of laparoscopic surgery in Strasbourg in France, Professor Jacques Marescou, who has done more than anybody else in the world in propagating laparoscopic surgery. My story returning back to Nigeria started in 2010 when the West African College of Surgeons UK Forum went to Calabar to do an outreach program coinciding with the 60th anniversary. And I did the first laparoscopy. I did laparoscopic cholecystectomy for the first time in January 2010. And there was a big fanfare. This is a lady, first day post-op, sitting out drinking tea. There was, the commissioner was there, the governor was there, the newspaper men, everybody. And I stood back. It was almost surreal to think, I do 5 of these a week, every week. And I've been doing that for about 5 or 6 years. And it's such a big deal here. And on my way back to England at the time, I made a solemn promise to myself that I was in the wrong place. I had to come back home to propagate and support laparoscopic surgery. And so that really, it wouldn't surprise anybody that I then found myself at Lagoon in 2010, September, by which time, initially I took a sabbatical from the university because I really wasn't sure what I was coming into, and I wanted the protection of my NHS salary and my university work. And so that was how I came up as chief of surgery at Lagoon. This was the operating theater in Apapa at the time. It's very interesting going back through this. All of this, unfortunately, this isn't working. You'll notice that virtually everything we're using, reusable. Cloth drapes. We had, the only thing that was really state of the art was this high definition camera and the wide screen at the time. But everything else was, you know, reusables. All of those things. But we had to do that because we really could not afford to make it too expensive. We had to find a way of ensuring that people could still afford what we were doing. Otherwise, we'll put people off. And a lot of the clientele we had were HMO patients. Again, very price sensitive. And we then had to say, how can we present the advantages of doing laparoscopic surgery, but in a way that the people who are paying could say, okay, grudgingly we'll let them do this and pay for it. And that was the biggest challenge we had at the time. And if you now, so by the time we moved into Ikoyi, things had, you can see we have multiple screens now. We were still using cloth drapes, but we had all the gizmos now. We had a harmonic scalpel, we had a ligature machine, we had a diathermy, and we had continued to make progress. And then when we came to Evercare, we even went one further step up. And now we were using reusable, disposable drapes, even more screens, and things have continued to progress. And that is progress, but it's not cheap progress. In 2010, I presented at the Association of Surgeons of Great Britain and Ireland the data for the work I had been doing in Nigeria in terms of laparoscopic surgery. So this here, so in the 10 years we had done almost 450 procedures, 155 appendicectomies, 231 cholecystectomies. It's interesting that we still did as many open procedures in appendices because we couldn't convince some of the HMOs the benefit of laparoscopic appendicectomies. I can remember one of the companies saying, well, the man will tell you that he's had appendix operation. It's going to take 3 months off work. So he might as well do that and let me pay for the open one rather than pay more for the lap one, and then he still takes the 3 months off work. So there was all of that to contend with. So we did a fair number of gallbladders. We also did some colectomies at the time. Abuchi Okaro started doing sleeve gastrectomies with us before he then moved to Eurocare, and he had done 8 by then. These were the rest of the procedures we did. I've now included another section, which is the 2022 to 2024, because in 2019, I went to business school so that I could learn how to be a proper CEO before I became CEO of Lagoon Hospitals. So for about 3 years, I wasn't really in active surgical practice. I was managing 5 hospitals at the time. There was COVID, and all hell nearly broke loose. I left in 2022, June, and then started Sapphire Surgeons, the Sapphire Partners. And although we still do a lot of these others, we were now concentrating more really on the high-end stuff. So in the 2 years, we had done 21 lap colon resections. Half of them at Evercare and half at other hospitals, and mainly 50-50 right and left colons. We've also, my colleague Jerome Ohene had done 24 sleeve gastrectomies and inserted 10 intragastric balloons, mainly for bariatric surgery, weight loss surgery, which really now is becoming a big issue. We've also done 6 laparoscopic gastrojejunostomies, which I find really very satisfying because people who have, say, pancreatic cancer or other terminal conditions that require a bypass, in the old days, we used to give them a big scar, and they didn't have long to live. So the little time they are having to cope with big wounds and all of that. But with the laparoscopic gastrojejunostomy, a lot of them go home. They are in hospital today. The following day or a couple of days later, they are home. Really very, very satisfying. So that's more than anything else I have found very satisfying. We've also done a distal pancreatectomy laparoscopically. I mean, we've done some splenectomies and a few other things there, but distal pancreatectomy was the first. I'm not sure it's been done elsewhere in the country laparoscopically. And Chinedu Ayandike is a urologist, and he's done, between himself and Kunle Akai, they've done 8 laparoscopic nephrectomies also. So that gives you a flavor of what we've done. One of the cases of lap colectomies that we did was a lady with cancer in ulcerative colitis. So we did a pan-proctocolectomy, taking all of the colon out laparoscopically. The specimen came out through the perineal wound, and she had a stoma and did very well. Because we wanted to continue to support other people in the country, we formed the Laparoscopic Surgery Society of Nigeria in 2014. And that was really myself, Wale Adisa, Abuchi Okaro, and Larry Balogun in LUTH. And we since continued to do annual programs of training surgeons. So this is the simulation. This is where I think they're going tomorrow. Yes, the LUTH Simulation Skills Center, which we launched at the time in 2014 through the support of Carl Storrs. And it's a really good training institute, and we really could do with more of those in the country. And what we try to do is to support other surgeons, mentor them, provide startup support for them. And in some of the cases, I also provide political support for them. If they're having battles with their CMDs because of equipment, then I go and talk to the CMD and hopefully get things done. I also talk to some of the equipment manufacturers to ensure that their services are seamless. I wish I could say that things have continued to improve, but we have had battles. The resource constraints, you see, it's nice that we're all here. This is a private hospital, but the guys that are coming to talk after me all trained in public institutions. So it is very important that our public institutions are working. It is very important because that is where the training takes place. If somebody is going to come to Evercare to pay top naira for their services, they will not want a trainee to do it. They will want somebody who is fully qualified. But that fully qualified person needs to start from somewhere. So for me, really, my passion is to say, how do we continue to support the public sector in embracing laparoscopic surgery? Because that's where the volumes are. That's where the training takes place. We can also train in the private sector, but nowhere near as the public sector, which that's their primary responsibility, and we really need to continue to support them. So this dichotomy of high volumes in the wrong place and where the resources are, the volumes are not there, is one of the things that we really need to think about how we address. And, you know, people perform. It shouldn't be an occasion that laparoscopic surgery is taking place in an operating theater. Hello, excuse me. It's normal surgery now. It should be considered as normal surgery, and that's where we're still not doing very well. The training centers are not there. We have one virtual reality simulator in LUTH. I'm not sure whether it's still working or not. And, you know, people fly in and fly out from abroad to support. Again, that's not sustainable. And we really need to see how we domesticate training in Nigeria. And this is not just us. I mean, this data from the East Africa also shows the difficulties they have. 50% of the equipment donated, only less than 10% of surgeons performing advanced laparoscopic procedures. So again, things could be better. Laparoscopic surgery is teamwork. There's no point in just sending, and you know, again, what Dr. Sanusi's talk at the end, he referred to the team. So the teamwork is very important. And with laparoscopic surgery, it's not just the doctors and the nurses. The anesthetists are important. The technicians, biomedical engineers are important. The procurement people are also very important because, you know, a lot of the things we use, you need the right supply chain. You need to ensure that they know what they are doing. They get you the right trocars. They get you the right catheters. All of those things are very important to get things going. And the biomedical engineering department has to be on top of their game because really there's nothing as bad as having downtimes. You cannot use the laparoscope because the bulb is missing. And then they say they are looking, no, you should have had a replacement bulb ready so that when that one goes, there is smooth transition. You know, all of those things are very important. Training is nowhere near in surgery that training is so important. And this training is also self-directed learning, and this was a study done in the States looking at year one surgical residents who were using the simulators to practice their skills. They compared them with general surgeons who were doing laparoscopic surgery but did not use simulators, and then with the expert surgeons. And if you look at here, so the expert, definition of an expert was somebody who's done 60 cases. The residents who were using simulator, the global rating score of their performance is that high. The general surgeons who are dabbling and trying without using regular simulator skills, look at how low their global rating score is. More important, it's also scattered like that of the residents. But look at the experts. They're consistently doing well. But some of the residents are just as good as the experts simply because they have been practicing using the simulators. So in laparoscopic surgery, and one of the, Zach Koto is a friend of mine in Joburg, another renowned African laparoscopic surgeon. One of the things he insists on is that when the residents join, they all need to invest in a laparoscopic needle holder, have a box trainer, and continue to practice suturing. Because the most difficult skill, really, is laparoscopic suturing. Continue to practice the suturing, doing a whole host of other things to improve their dexterity. And so this is the sort of thing I'm talking about, where these folks here are outside of an operating theater, and they're practicing on a virtual reality simulator. If you do 10 gallbladders, so the thing is that here you could do 10 laparoscopic cholecystectomies a day, but you can't do that in humans. So you can see how quickly one can go up the learning curve. You can do 3 or 4 colectomies a day using the virtual reality simulators. But it's got to be a structured training program to ensure that things are done properly. And there are different ways in which this training can be done. I've shown you the box. So this is an example of the box trainer. Some of you will recognize Oludara there, Lassuth. And it can easily be, that's the standard one, but it can also be improvised. Or you can go to ERCAD in France, ERCAD in Kigali now, where at the Kigali Center in Rwanda, there are 15 operating tables with anesthetized pigs, and then you have an instructor per table, and usually 2 participants. And we spend a week going through the different forms of laparoscopic. Dr. Arinze was there with us earlier this year, and he's shaking his head in agreement. So it's a good resource, and people get to actually get hands-on training. There are a number of solutions that we need to look at. One of them is access. You know, there's no point in doing all of this if people can't. You know what it is about healthcare? If it's not really accessible, then it's not good healthcare. So you could provide care, but it has to. We need to think of accessibility, and really the sure way of doing that is through health insurance. I think we also need to look at, this is controversial, I hope I'm not going to be quoted, but the truth is that if you look at the teaching hospitals, the public institutions, it's got to be pay for performance. It's rather than just allocation to say you get this subvention of X millions of naira and you don't, there's no proof that anything is done. Why not say, okay, for this X amount of naira, you do this number of procedures, you treat this number of patients, you have this number of deliveries. That will probably focus their minds and provide better service for the citizenship. I don't know whether that's going to happen, but it's just a thought. The other one is strategic purchasing. Now, in Kenya, what they did was they went to GE to say, look, we want to buy 15 CT scans, and rather than the $800,000 that is going to cost us, we're going to pay $500,000 for it, but we're going to buy 15 from you, not the 1 or 2 or 3 that people will have bought. So with that, the economy of scale, they are then able to then invite the separate hospitals, including the private sector, to say, there is this opportunity to get this. Imagine the cost savings that will come from that. So that's thinking out of the box. That's been very clever. And we also need to start, but the problem we have here is that we are very, very reluctant to collaborate with each other. And until we start to do that, we will just continue to struggle unnecessarily. We also got to train the local guys, encourage the public sector to train, encourage the private sector to train, and we need to mentor people. We need to support them, because there is no point in one person just being a superstar without, cascading and supporting other people. And we need to have centers of excellence. And, the final one will be if we can produce some of this equipment ourselves, because at the moment, dollar is in short supply. There is the Bariatric and Metabolic Surgeons Society of Nigeria, which was formed in April of 2023. It is another one step further from LASSON in ensuring that the people who practice metabolic surgery and bariatric surgery come together to support each other. In terms of collaboration, what we have done is formed together what we call the Sapphire Partners. All the 4 people I referred to earlier, we now collaborate, and we've been working out of Evercare and 2 or 3 other hospitals in Lagos. We have a center now also where we practice minimal access surgery, and we train and we support people across the country. So that's that with the situation in the country. I just want to mention 1 or 2 things about recent advances. So the first one I'll talk about is indocyanine grain, and this helps us as colorectal surgeons now to reduce the risk of anastomosis when doing laparoscopic colorectal surgery. So the dye is given, and what happens is that the tissues turn green from the indocyanine. So the dye goes through the blood vessels and plasma. And so areas where the blood supply is poor, the green dye will not be there. So this was a bowel that was being prepared for anastomosis here. And that's the stump of the colon. But if you see here, that stump of the colon is not green. So that means the blood supply to that is not good enough. And there have been publications to show that with the indocyanide grain, anastomotic leak rates have almost reduced by 50%. So that's one of the areas we're looking at in ensuring that we improve the outcomes of patients. Another is complete mesorectal excision, which is the son of total mesorectal excision for rectal cancers. And complete mesorectal excision really relies on the anatomy or the embryology of the colon to dissect out, clearly identify the right colon, remove all of the blood supply and the lymph nodes from the source. So right hemicolectomy used to be a nice, simple operation to do, but with complete mesocolic excision, one needs to learn all the anatomy again, particularly around the pancreas. And there's this beast here called the Henle's trunk. Some of you will know Henle's loop, as a German anatomist. And Henle's trunk is just a short stump of vessel, which is a branch of the gastroduodenal artery. And it splits into the superior and inferior pancreatico-duodenal arteries. Anybody that has been manipulating that bit of the bowel with a version of the vein knows how, scary. Because easily the patient can lose 2 or 3 liters start, and then heavy resuscitation needs to take place. But what this has done is that it has reduced the recurrence rates and the survival of patients with right colon cancer. And we are forever looking at how we improve outcomes for survival of patients with cancer. Dr. Shonibare talked about robotics. We would like one. We are preparing a place for one, but we don't have the $2 million yet both for the procurement and startup. But I know that the intuitive patent is going to run out very soon. There are 53 companies in China currently working on robots. So remember what the Japanese did to the Germans in the 70s and 80s. I think the Chinese are going to do the same to the Americans because in another year or two, we'll be able to get a robot for $500,000, I'm sure. And when that happens, there are certain advantages to the robot, particularly for prostate. Robotic prostatectomy now is the gold standard because it's in a confined space. The robot has 3 arms, as many fingers as you want, and that just improves the ability to do complex procedures. Augmented reality, I mean, what happens with that is then with image guidance, allows people to define accurately where to incise, which part of the brain or the body to resect, and again, is another way of improving outcomes. Artificial intelligence, I know there's been a lot spoken about artificial intelligence. A lot of the virtual reality simulators also are based on artificial intelligence. They work on the platform of artificial intelligence. So it's been well established. For us, there's certain applications in surgery. The first one, which is now in practice, is the AI-enabled colonoscopy, whereupon if you are doing a colonoscopy, those who have had colonoscopies or are familiar with colonoscopies, we are looking for polyps. Polyps, if left alone, will become cancers. But through developing algorithms and feeding the data into the computer, the colonoscope now, when you are doing a colonoscope, it can identify polyps that are less than 6 millimeters, that the eyes may not see. And it will then, and I'll show you a picture of that in a minute. The other one is callus triangle. Callus triangle, when doing laparoscopic cholecystectomy to remove the gallbladder, the biggest issue, the risk, is damage to the common bile duct. And injudicious messing around with the callus triangle can cause damage to the common bile duct. So there is now, again, an algorithm to say that, AI will tell you, no, you haven't done the callus triangle dissection properly. This is how to do it. And you are then able to safely divide the cystic duct without damaging the common bile duct. And the top slides are the normal colonoscope. And if you now use an AI-enabled colonoscope, you could just about see that little blob there. I don't know whether the resolution is good enough. But what the AI colonoscope does, it puts a square there to say, hello, don't go past that. There is a polyp there. And, this is coming into practical use. The other one I spoke about is the callus triangle, where the AI would provide the image, superimpose it, and flash if it feels that you are not in the right area. There are, of course, challenges. Data privacy and security is one. Bias and discrimination. In terms of the algorithms that are used, a lot of this work has been done in Caucasians and Asians. So you could argue that we may have a different scenario in Africa, and certain risks abound with that. There is no regulatory framework at the moment, and there are concerns about that. You could say that if you rely too much on technology, then there is a risk that you may actually lose the ability to do things properly. And it's very expensive. I don't think there's anybody with an AI-enabled colonoscope this side of the Atlantic Ocean yet, but I'm sure that it will come. So in summary, ladies and gentlemen, general surgery and minimal access skills have about a 20-year history in Nigeria, and we're making progress. We have made some progress. It's been slow because of poor healthcare funding and access, and the resource constraints that we have, and also because we could train a lot more surgeons. And things are changing now, but previously it was really a battle when I go to the teaching hospitals to try and train. There were so many obstacles at times. I said to myself, why am I doing this to myself? But I can't stop. We've got to continue. Simulation training is important so that we can go up the learning curve. Health insurance really has to be key, and we're hoping that this new Health Insurance Act, with the compulsion for everybody to get health insurance, it is our hope. And I've been speaking to Kelechi, the DG of NHI, to say we also need to look at how we fund minimal access, because the benefit to the country, the healthcare system and the economy is significant. There is increasing role of artificial intelligence, both in the training and improving safety during minimal access surgery. And I'd like to say a very big thank you for giving me this opportunity to talk to you. Thank you.
Thank you so much, sir. Please, if anyone has questions, we have the mic going around the hall. Please indicate if you have a question so he can attend to them.
All right, Dr. Adekunle, I'm Medical Director at Mobile. So Dr. Coker, is really not a question for you. For people that may not know my history with Dr. Coker, he's my doctor. And we've come way back. It's just to say thank you. And really, really thank you. Thank you for applauding him also. For many of us younger, doctors that have passed through the teaching to the private sector, it's difficult, and we see it. We all just want to take care of our families, take care of ourselves, but when you see the older ones that take it upon themselves to get people trained and then to push the boundaries, and get things properly set up, it is a challenge. Paying for laparoscopic surgeries in Nigeria is a challenge. I work with an organization that's ready to pay for the best. But when you go out there and you see the cost, and you have human resources and other people ask you questions, why are you doing this? And say, this is what we believe in. But there are not so many organizations that are doing that. And today, I want to put a challenge to the HMOs also. I hope we have many of them here. Most HMOs are still not paying for laparoscopic surgeries, and it's because of the cost. But thank you. We're starting from somewhere. We're pushing it. The more we have out there. But I think what I would really love to see is many teaching hospitals having laparoscopic surgeries to train medical students, to train residents. The more people we have out there, the more affordable it's likely to be, and then the more popular it's likely to be. But we have started. And I want to say big thank you to you and to the pioneers of this. Thank you, Doctor.
Thank you very much, Dr. Adekunle.
Good morning, everybody. Yes, my name is Chinda Diane. I'm the head outpatient department, Total Energies. I am a nurse, a midwife, and an operating room nurse. But I'm happy to be serving in Total Energies. But unfortunately, I'm not practicing in my passion area. My passion area is operating room. But I found myself where I found myself. I'm enjoying it, but in terms of career, I'm not fulfilled. I'll say it any day, anytime. Total Energies, they know. With no apologies to anybody. But I'm taking an early retirement from Total Energies in a few months. I'm not yet 60. I'm still very functional. But I want to give back to the society. And where am I coming back to? Back to the surgical room. And my question goes back to, how can we incorporate to have the nurses trained in this area of laparoscopic surgeries? And here am I, interested to join the team, even as a volunteer. Even if it means training me outside the country, I want to join the team. So how can we have the nurses trained, and I can help to lead the train? Thank you.
Thank you very much. It's there is the society. I think in one of my slides, I know I glossed through the nurses training, and there is a Society for Nurse Endoscopists of Nigeria. And I think that the first step is to connect with those people. Unfortunately, 3/4 of them have jackpot. But I'm hoping some of them will jackpot. Oh, you are still there. You see, some of them are still there. So that's one step. ERCAD in Kigali also run advanced laparoscopic training for nurses. So there are opportunities. I think the part of the problem is not knowing the right people, and you've got one there who would be able to link you up. Thank you.
Good morning, all. My name is Shola Keti, representing the Special Advisor, Dr. Kemi on health. Sir, I want to say a very big thank you, sir, for giving back to the society once again. After the likes of Professor Akinola and the rest, we are looking at what will happen next, and I'm happy that you are taking up the battle from where they stop. Giving back to the society with your experience has been a fantastic experience. And like you said, attrition has been a steering factor to our health sector. May I request that at our private settings, we need more of the intellectual properties like yours to come into the field. But like you said, you have so many challenges, which I believe can easily be taken off. By you speaking directly to my Commissioner of Health, is a learned person, intelligent ones for that matter, and internationally recognized. And with the inclusion of Dr. Shonibara, I believe that we can get this thing done around the table. Because we are thinking of our society, and Lagos is said to be a country inside a country. And so if you can have some intellectual ones coming together to have a strategic meetings, things can be taken around. I won't say that attrition, yes, is a factor, but it's a thing we can see right about it all. However, most of our clients outside the shore, they are now coming back to Nigeria to receive their health. And so if you don't have the expertise to do that, how would they be able to? Because outside the country is expensive, but they find Nigeria as the best area to come into to have their treatment being obtained. So may I request that engagement with the Lagos State will be another benefit to the entire society, especially Lagos State. Thank you very much.
Thank you very much. Noted.
We'll just take one more question, okay?
Thank you very much, Dr. Koka, for the lecture. Just on a lighter note, I realized one of your slides, you put a team of professionals that you work with, and I saw that the nurses were there down to the procurement officers, and there was no place for the pharmacist. And so I'm speaking as a pharmacist, that I think we have a role in the OR too. I mean, we know we have medications that used to anesthetize your patients, and that is where pharmacists also could be part of the team. So please, I would appreciate if your slide is, corrected and the pharmacists are included. Thank you very much, sir.
Thank you.
Thank you. But the mitigating factor is that it's the anesthetist that usually organizes the drugs. So I just liaise with the anesthetist who liaises with you. So if we were drawing an organogram, then we'll have put you below the anesthetist. But thank you very much. Okay.
Please just put our hands together for our keynote speaker.
Thank you so much, sir. Thank you very, very much. Very, very enlightening presentation. We were moving on. We're actually keeping to time, and that's really a good thing. We're going to change battle. I would like to introduce the MC who will take on for the rest of the event. His name is Ebuka. So Ebuka is here. He will take on with the rest of the event. Can we please welcome Ebuka? Thank you.
Please, a round of applause for Chioma. She's done such a great job. Thank you very much. I'm sure some of you are wondering, who is this fine, handsome, tall gentleman? Like she said, my name is Ebuka Mike, and I believe that I'm the finest man alive. Those in favor of that motion say aye. Those against say nay. Bad belly, bad belly, bad belly. All right, thank you so much for coming. And once again, I'd like to welcome us all to this gathering of elite minds. I want us to just put our hands together for Evercare Hospital Lekki for putting this together. I also want you to count yourself most privileged because this is the inaugural surgical colloquium. This is the first, and you are a part of history. Thank you so much. I'd like to also acknowledge respectfully all the speakers that have come up here for sharing so much with us, so much insight, so much knowledge. We're going to be going on, but before then I observed that some people All right. So I observed that some of us during the presentations, we were trying to find our way around. I'm just going to give us just brief information. If you're looking for the restroom is just outside the door. If you take your walk, when you come out the door, take your left, then you take another left, you'll be right at the restroom. A little health and safety tips. If there's any emergency, relax. There's so many doctors around, so. Yes, and in the case of a fire emergency, just calm down. Just organize yourself properly. Don't look for the MC. I would have gone by that time. So, but yeah, just on a lighter note. I want us all to also take photos, right, with Dr. Olujimi Koka before he leaves. So I will start at a particular point in the program. The ushers are going to give us directions on where to go and how to do that. Okay. Yes. So we're still going on, and we're still, getting so much information, so much enlightenment. Our eyes are being opened to various things that are happening already in our country, Nigeria, and happening especially through Evercare Hospital. Now, the next speaker that is about to come up is one of the brightest minds I've ever read of. And I'm going to just be reading his profile. I want you to listen before he comes up. Dr. Arua Igwe Obasi. Dr. Igwe Arua Obasi is a distinguished pediatric surgeon at Evercare Hospital, Lekki, known for his expertise in pediatric general and minimal access surgery. His specialty lies in performing surgeries for congenital anomalies, pediatric, laparoscopic, and thoracoscopic surgeries, as well as pediatric surgical oncology and urology, showcasing a comprehensive range of skills and knowledge in the field. Dr. Obasi has achieved significant surgical milestones in his career, pioneering advanced minimal access surgery techniques for children in Nigeria. He has accomplished several firsts in the region, including the first infarct laparoscopic pyelopastry, first thoracoscopic repair of esophageal atresia in West Africa, the first laparoscopic uteric reimplantation in Nigeria, a laparoscopic assisted pull-through for H-sprung disease. His training background includes a surgical residency at Obafemi Awolowo University Teaching Hospital, Ife, a fellowship of the West African College of Surgeons, as well as comprehensive basic and advanced laparoscopic surgery training, highlighting his commitment to continuous learning and innovation in the field of pediatric surgery. Ladies and gentlemen, distinguished people, gentlemen of the press, Assembly of Doctors, join me welcome Dr. Arua Igwe Obasi as he comes up.
Good morning, everybody. Still 10 minutes to afternoon. I will just be talking about what we've done at Evercare with pediatric surgery, minimally invasive surgery. Mostly we deal with a lot of congenital anomalies, and a lot of things that I want to say here have been said by Dr. Jimmy Koka, who is one of my mentors in minimally invasive surgery. So, next slide, please. Okay, yeah. Okay, so this is our hospital. So, different views of the hospital. This is the neonatal intensive care unit at Evercare, where we manage most of our patients that have had surgery and preterm babies. So congenital anomalies are one of the leading causes of global disease, and of course it's very, very prevalent in third world countries, poor countries also, and is responsible for about 57.7 million disability-adjusted life years. So, and it creates a lot of burden of disease in the country. One of the issues that we have is in our country where a lot of births are not being recorded, a lot of patients, a lot of babies die, infant mortality rate is very high in our country, and majority of these babies are usually due to congenital anomalies which are either not treated, not picked up, or not being properly managed. So minimal access surgery has been in existence in our country for a while, and it started from gynecology and later progressed to general surgery. And also, pediatric surgeons were one of the last to embrace these parts of surgical care. And since then, up till today, we've still been struggling quite a bit to make it a standard of care in most of the conditions in children. Then there are several reasons for that. Number one is there is this myth in pediatrics or in generally when you're treating children, do they really feel pain? They say no, they don't feel pain. That's why in some places where I see them doing circumcisions, they don't give any anesthesia. They just, bring the thing and yank it off. Just like that, and the child is just crying, which is very, very cruel. Every baby feels pain, just like you and I do, and they just can't tell us. They will not be able to tell us how much of the pain that they are feeling. So anything that you can do to reduce or eliminate that pain is highly welcome. So they do feel pain. It's not working. Next slide. Sorry. Okay. So the next one is cost. What I discovered during my short time of practice is easier for an adult who is working, to say, I want a laparoscopic cholecystectomy. But in Nigeria, especially, I can say this for majority of the third world countries, when you bring a baby to the hospital and they say this condition can be treated with minimal access, and you say, I have 5 children at home, and you want me to pay this amount for minimal access surgery, when you can just open it and do it the way others have been doing it. There's a lot of things making it difficult to convince the public that children actually will benefit from minimal access surgery. And once you bring the issue of cost, I had a bad experience as a copper when I had a child with cholera, just for the parents to buy 2 pints of normal saline. The man said, no, I cannot spend 500 naira on this patient, on this baby, when I have 7 children at home. So because of that alone, if it was the father that was sick, I'm sure he will bring out the money. But the way we have that, the mindset we have is that we don't want to, make that kind of investment on that kind of child. So that's a big problem in third world countries, the cost. But when you look at the cost benefit and the relative benefits after the surgery, these children recover faster, they have less morbidities, and they go on to live a normal life afterwards. Next slide. Okay. So one of the challenges we also had with managing children with congenital anomalies or doing minimal access surgery is the instruments, because they weren't thinking of us when they were making laparoscopy, like, we're thinking about people like Jimmy Coca and others. So they made ginormous instruments. so we can't use this for these babies. The baby would disappear inside the instrument. So we had to make smaller instruments for this to achieve the same result for our babies. So most surgeons find these procedures very difficult. One of the reasons is the space that you're working in is very small. Imagine trying to repair an esophagus in a baby that is 1.2 kg. So the chest is as small as a matchbox, and you want to do it minimally invasive. So when you think about just wrapping your mind around that alone, makes you feel, oh, this is going to be very difficult. But at the end, if the expertise is achieved and this patients go ahead to have these surgeries, the results are much more rewarding. Most pediatric surgeons outrightly rejected laparoscopy because they already pride themselves in doing surgeries with smaller incisions. Like where I come from, it was, quite a challenge for me to convince everybody, oh, I want to do this case laparoscopically. They have to bring everybody to make me see why do you want to do this particular case when you can just go through like this and then do it like this. But you have to bring out all the reasons why these patients will benefit from this minimally invasive surgery. This is a muscle cutting incision. You have to go through muscles, you have to, open this abdomen to do something very small. But when you put in just a single camera, you can do everything, from that single port. Okay, so these are the history of laparoscopy in children. I've said those things before. So now these are my mentors. One of the things about them, the first two really are not really laparoscopic surgeons, but these are very senior people in pediatric surgery who told me, I will stand behind you while you go and learn this procedure. And we need such people. Some of the people that trained us were not really with us. The last two surgeons, I've never met them. I've never seen them before. They don't even know me. But they pioneered the most complex minimally invasive surgeries in children, and they made it public, and I was able to learn from them. Professor Adejare is one of the bedrock of my laparoscopic surgery journey. He's the one that took me in and said, you do that surgery, I will stand behind you and make sure that you do it properly. And these are the people that we need, and I am also willing to transfer this knowledge. That is why we are organizing this colloquium. So how did I start? This is one of the way we started in Ife. So I don't know if this is working. So it's not really working. If you look at this is, I don't know if you have heard of cathode ray oscilloscope. So that's the first, that's the first monitor that we used. Our CO2 insufflator had these manual gauges, that ticks like this. So yes, exactly. So that's our diatemy machine that Professor Adejare brought in, and he set up this cart for the first time in Ife. And he used this, surprisingly, to do some laparoscopic cholecystectomies. So after a while, we were able to upgrade, mind the word, upgrade. That's our upgrade. Still, the cathode ray oscilloscope, and we got a better insufflator. That was, a smaller insufflator, which we also used. And this was good enough because it helped me. It was able to insufflate up to 6 mm of mercury. So that was the one I can use for kids. This one was a no-go area. So now, after a while, just to manage our cats better, you can see this just on a trolley. So we had to construct that to put our cats on top of it. That's last picture there. So it was constructed by just a welder by the side who painted it for us, yes. So my CMD at then, Professor Adejare, he was gifted this tower. Yeah, this one. So, and it was locked up for a long time. When we come in a wonderful hospital like that, they will celebrate the tower, they celebrate the machine, and then we lock it up. So that was that tower. It was locked up for a very long time until 2014 when I passed, became a senior registrar. So I said, no, I want to do laparoscopy. He said, oh, yeah, there's a tower there, but check if it's working. So we went there and opened it. That was how we started organizing. We bought so many things from Amazon to make it, work. And it worked. I did about 50-something surgeries with that cart. Yes. So that was when we bought a new screen. We had to buy a, color TV to change our cathode ray oscilloscope. But this is where we are now at Evercare. So we can boast of so many monitors and, all the rest. So what are the things that we can do in children with minimally invasive surgery? Almost anything that is in the body cavity can be treated, apart from CS, can be treated with minimally invasive surgery. So we have done esophageal atrasias, we've taken out half of lungs, taken out parts of lungs. We have done patent ductal arteriosis, like Professor Sanusi talked about. I've done 2 thymectomies, intestinal atrasias, biliary atrasias, and all whatnot using minimally invasive surgery. So just to show us a few of the cases that we've done, this is a child with Meckel's diverticulum, a 3-month-old baby who presented with bleeding. So this is the view of the abdomen when you are doing, when you are removing a Meckel's diverticulum. It's simply something like this. It looks like a pouch in the intestine, and it produces, acid because it contains gastric tissues. And that acid causes bleeding for these babies. And you just see a baby that is bleeding per rectum. You don't know the etiology of the bleeding. And with a nuclear scan, you can identify the Meckel's diverticulum, and we just snip it out. That's one of the simplest procedures aside from appendectomy in babies. So that's a diverticulum. The next one is a very complex condition called intestinal atrasias. This child presented as day 2 of life with recurrent vomiting. Now, if you watch, you will see a part of the bowel that is so humongous, and the other part of the bowel is very small. So the one that the suture is going on is very, very small, looking very, very small, while this one is so, so big. The reason is because there is a congenital obstruction between the 2 areas. The one that we are cutting now is the big part, while this thread-like one is the normal part. So now, we have to join this laparoscopically. Mind you, this baby is just 3 kg. Just 3 kg. And with the laparoscope, you can appreciate this surgery much more as against when you are doing it in an open, a surgical technique. So with these incisions, it's easy to, join the 2 together. So at this point, you can see this needle they are looking at is very, very small. It's just 13 mm needle, 13 mm size, very, very small. And you can appreciate it on the screen. And with this, you can do very fine, suturing and joining of the intestinal intestine together with much more precision. So another condition is Hirschsprung disease. Surprisingly, in our environment, I've seen a lot of patients with Hirschsprung disease. And this is commonly due to absence of innervations of the intestine or the distal colon. Now, this will cause constipation. You can see this is the colon, the sigmoid colon, looking very, very huge because the child is unable to pass stool. So what we do here is to dissect, do a sort of left distal hemicolectomy with sigmoidectomy. That's what actually it entails. Down to the rectum, and then we pull it down through the anus. Now, at this point, it's important for us to preserve the arteries of Drummond, which is what supplies the distal part of the rectum, the distal part of the colon for our anastomosis. With minimal access surgery in Hirschsprung disease, it helps us to minimize the work that we do in the anus. Because one of the complications of this surgery, which I have witnessed during my training, is fecal incontinence. And one of the things that causes it is recurrent stretching of the anus while you are doing the surgery through a transanal route. But with laparoscopy, most of the procedure is done inside laparoscopically, and then just about 30 minutes or less, you do the transanal pull-through and do the anastomosis through the anus, and the patient goes home with good continence and good, function, bowel functions. That's the last part of the surgery. So one of the cases that we did at Evercare is a congenital diaphragmatic hernia. This child presented to us from a nearby hospital on just about 12 hours after delivery because the child could not maintain respiration. Sorry, that was, okay. So the child could not breathe properly. And because of the people, we don't really know what is going on, and they try to ventilate this baby with non-invasive ventilation, they worsen the child's problem because the bowel is inside the chest. So when you bag the patient, you increase the air in the bowel and you compromise the respiration further. So luckily enough, one of my colleagues was called to see the patient and he promptly referred the patient to us, and we had to repair the diaphragmatic hernia via the thoracoscopic approach. So that was the muscles of the diaphragm being sewn together. This child had this surgery immediately. He presented to us at Evercare. Of course, because his echo results were looking very normal. Usually we don't repair this as an emergency, except when we have good echo reports, because they usually present with pulmonary hypertension. So after the surgery, the child had a very beautiful recovery, was discharged about 5 days post-surgery, and this is, the child is a year old now, and they're running up and down. So, and the parents are really grateful. So now, this is another condition we call PUJ obstruction, that's pelvic ureteric junction obstruction. This child presented to us at 7 years of age. He has been carrying this for a long time, recurrent loin pain and infections. When we did our urogram, we discovered he had a PUJ obstruction. You can see that dilated pelvis. So we had to do a laparoscopic pyeloplasty for him. So now this is one of the most delicate anastomosis that you have to do because the tissues you are handling are very, very small. And the sutures must be placed accurately on these patients. So it's one of the most delicate procedures one can do for these children. So he had this procedure done, and we removed the constricted parts of the ureter and reconnected the ureter to the pelvis. After that, we passed the stent, and the child carried the stent for 3 weeks, which was removed later on. Now he has a very good renal function. He came in with a renal function of less than 20, but now both kidneys have 50, almost 50-50 renal function because he didn't have a very significant compromise of the renal tissues before surgery. Now, this is a child that presented to us as an emergency. I saw this child initially when the child was in the womb. That's one of the advantages of prenatal diagnosis. So the mother presented with severe polyhydramnios, and when we did a scan, we discovered that the esophagus was atretic. So when the child presented, it was 1.6 kg when it was delivered, and we did thoracoscopic repair of esophageal atresia for him. So you can see that in this child that has a very small size, I don't know if I will ever want to do this procedure open anymore, because I cannot have this kind of view when I'm doing it open. One of the problems of open surgery is that it is only the surgeon that is seeing. The assistant will not see anything. He will be busy retracting the lungs while doing the procedure. But here everybody will be seeing the procedure. That is the proximal esophagus being dissected. The esophagus being dissected, and everybody can see that is the esophagus. Then the distal one, you can see the sutures being placed, and that's the distal esophagus that we are also connecting the proximal to. And after this surgery, it will look as if this child never had any surgery, because you just see 3 marks on his or her chest, and that's the end. So in this child was particularly difficult case because the distance between the two esophagus was relatively long. So we had to apply some important techniques like sliding knots and all that to pull the two esophagus together under some degree of tension. Despite all that, the child made a very smooth recovery. You can see how that esophagus was coming in, together. So this child was discharged about 20 days post-surgery because he has to be on mechanical ventilation for about 5 days before we extubated. So another one we did that was very interesting was another esophageal atresia. One of the things that we do in teaching hospitals, because of poor facilities, is we do these surgeries in stages. Surgery that we've been doing single stage. Now, because of poor facility to manage these patients, they tend to disconnect the esophagus entirely. So this patient came to me at the age of 1. Initially, they were planning to travel abroad, but because the child fell sick, they had to come in to a closer hospital. So we did a combined thoracoscopic and laparoscopic gastric pull-up for this child. What it meant was that we had to remove the entire esophagus. So here is the thoracic part of the surgery where I had to, dissect this entire esophagus completely. So after that, the atresia was still there, the fistula was still there. I had to close it with a clip and join an NG tube to the esophagus. So that helped me to be able to pull the stomach from the abdomen into the chest. So that was what we used to replace the esophagus and remove the entire esophagus from this child. Now, the last time I saw this surgery done was done open, and it was done by one of my mentors, Professor Nakpoya. So I imagine the incisions that we had to make on this child and the morbidity that we did, that the child went home with, though the child, survived. But this index patient I'm talking about now had almost no scar, just the areas that we had to put in these instruments. This is the laparoscopic part of the procedure. This child has already had a gastrostomy done, so that's a gastrostomy that we're taking down. Gastrostomy simply means a tube that will pass to the abdomen to feed the child. So that's where we are taking it down to mobilize the stomach for the surgery, for the replacement. Sorry, this is a relatively long clip. So, but I would like you to see the end of this surgery. So that was the stomach. One of the things in mobilizing the stomach is there are important vessels that we want to preserve that will help us to supply the stomach, and we call it the gastroepiploic arteries. So the dissection here is painstakingly done to preserve those vessels. The challenge I had with this baby was adhesions. Adhesions usually occur when open surgeries are done, and because she had had an open surgery initially to place the gastrostomy, so she had multiple adhesions. So we had to take down these adhesions carefully while preserving the vascular supply to the stomach. Okay, so at this point now, we have almost completely separated the stomach. It's now time for us to mobilize the esophagus from the abdominal part. So this child spent about 8 hours in the theater doing this surgery. This thing is not working. So if you look at that point, you will see us, that's the esophagus that we are already dissecting down. That's a sling, especially when you are doing something like a fundoplication or doing, you always put, that sling to go around the esophagus to, get some traction. So that's the esophagus that we are mobilizing already into the abdominal cavity. Okay, so you can see that that's my NG tube, the one I put in the chest there, showing, I don't know if you can see that already. So coming into the abdomen already. So one of the things we do here is we have to do a pyloromyotomy for these patients, because once you mobilize the esophagus completely, you have already destroyed the vagal trunks. So you have to do a pyloromyotomy to allow the esophagus, the stomach to empty properly. So that's what we did before we, now I had to exteriorize the esophagus, the stomach completely to put, so that's the baby after surgery, eating very well now. After the whole surgery, the parents allowed us to share this video. So that was that. So the last but not the least is patent ductus arteriosus, which is Dr. Sanusi mentioned this case. So this was a baby that was born with 1.1 kg early delivery. So she had a patent ductus arteriosus, which we ligated. So with this, I could easily see the subclavian artery. We could easily see the aorta. And we can also easily see the ductus arteriosus. So with Dr. Sanusi, with me, we were able to ligate this, using thoracoscopic approach. And this was the very first in West Africa to be done thoracoscopically. And the esophageal atrasias, we are, proud to say, we pioneered it in West Africa, doing thoracoscopic repair of esophageal atrasias. And we have also decided to be going out to train people on how to do it. One of the places that we've gone to LUTH, and we've done one of the surgeries with them because they have a new kids OR tower that they have. So we have gone there to also do one of the cases with them. So that's the PDA here. You can see it very easily, very, very easily with the arrow. So with that, just a single clip will, ligate that PDA. Okay. Now, all these procedures were done not just by the surgeon, but by the whole team. There was a lot of support, from the care team, from the nurses, and then my amiable pediatricians and neonatologists. There's no successful pediatric surgeon without a good neonatologist and a pediatric intensivist. So that's the clip closing the PDA, and that was the end of the surgery. So this surgery took about less than 45 minutes, and we were already done. That's the intraoperative echo that showed complete closure. So another surgery, this is lobectomy. We removed the entire lungs of this baby with thoracoscopy. So this is a urinary reflux. So many procedures that we've done using minimally invasive surgery. And all of them range from neonates to children older than 10. And this is the range of procedures that we've done, including Hirschsprung, henioplasties, and all that. So the commonest surgery that we've done here is Hirschsprung disease, followed by appendicitis and esophageal atrasia. This is 7%. Most of them were laparoscopy, were thoracoscopies, and some of them were laparoscopies. Yeah. So outcomes, see that's the child that had esophageal atresia. See the chest, almost no scar. Meanwhile, if it was open surgery, you will see a very long incision on the chest. And this one had laparoscopy. So this child had jejunal atresia. There was almost no scar. This is another child with, that had thoracoscopy. So these are my team, and also some of my patients that were grateful for their surgeries. And this is one of my, the smallest baby I operated, 1.1 kg. So there was smooth collaboration with neonatologists and pediatricians. We still need to, continue to advance our minimal access surgery and continue teamwork and continue the training. Thank you so much.
Thank you so much, sir. Please, can we put our hands together for Doc? I think we'll take a question and answer segment towards the end. Please put your hands together for him one more time. Thank you, sir. All right. So now, for those of us that were really interested in, some of the videos that we saw, I would like to also know more. Tomorrow, which is the day 2, it will continue with a dry lab workshop, which will be led by Dr. Arua himself. Tomorrow by 9 a.m. at LUTH. So I think, and I encourage that we make ourselves available tomorrow, 9 a.m., to be a part of it. Now, like I said, we have the Evercare Hospital Lekki paramedic on site with an ambulance task for any emergencies, so rest assured that everything will be fine. Now, before I continue, there was a question. Now, like we earlier announced, we are streaming this event online. We have lots of people all around the world that are listening in and watching. And so they have questions too, especially when we're taking questions for our keynote speaker, Dr. Olujimi. There was a question that came in. I'd like to read to him, and if you could just answer our online viewers, Choma will help. It's just one question. It says, how can laparoscopic training be made mandatory rather than optional in the curriculum of surgical trainees in Nigeria, just like it is?
Yeah, thank you. We are currently working with the colleges, I'm working with the West African College of Surgeons, and Dr. Adejare is working with the Nigerian Postgraduate Medical College, the surgical division, to develop a curriculum for training, which will be adopted. A note of warning, though, one could develop a curriculum, but laparoscopic surgery is a technical, equipment-intensive undertaking. So if the wherewithal is not there to practice it, then that then becomes a bottleneck. So it's not in isolation where the curriculum is almost developed. What then is the next step is trying to ensure that the facilities will be there to support the trainees with laparoscopic surgery. Thank you.
All right, please. Thank you so much, sir. I believe that was quite clear. Now we'll be moving on in the program, and at this point, we'll be having a tea break. We've refreshed our minds so much with so much information. It's time for us to also take a break, have some tea. By the right of the hall, if you would observe that we have tea, we have snacks, and what have you. The ushers will direct the flow. And so just let's cooperate with the ushers. And during the break, it's just for about 15 minutes. By the time everyone has gotten tea or gotten some snacks, I also like to encourage discourse. I like to encourage networking. Meet someone new, talk to someone you don't know. That's one of the goals of this colloquium too, is to facilitate collaboration, facilitate connections, facilitate relationships. Just for the next 15 minutes, after which we'll come back and continue as we have some other incredible surgeons in the house to share with us. So please, let's just cooperate. There's enough to go around. Let not your heart be troubled. Yes, it's the ushers that will direct, like I said. The ushers will direct the flow. So just be patient when the usher signals you. If you're wondering who the ushers are, the beautiful ladies wearing gowns, those are the ushers. And if the Lord inspires you, I'm just joking. Okay. We have about 15 minutes, I believe. That'll be more than enough time for us to successfully have gone round. Those of us that are social media savvy, I'd like to encourage you to also take the discussion online. You can tweet on Twitter, Instagram, or Facebook. You can also bring out your phone, take a video. The hashtag is... Are you waiting for the hashtag? Hashtag Evercare Surgical Colloquium. If you cannot spell colloquium, N-O-E-I. I'm just joking. Hashtag Evercare Surgical Colloquium. And please, when you take your teacup or your snack or fruits, please, you could come back to your seat so that there's no crowd at the table, so that others can also find their way through. When the ushers signal your table, you could move to the coffee table, the tea table rather, to have your own portion and share. And relax, this is not a Nigerian wedding. The small chops will go around. Okay. All right. You could also follow Evercare Hospital on Instagram. Evercare Hospital Lekki is the handle. And you can tag them on your posts. You can put it on your stories. Those of us that are Gen Zs in the house. Let us show our Gen Z. Laparoscopic is on. Okay. Next time you'll see me, you'll need to commence the session. So enjoy your break, connect with people, have a good cup of tea. I'll see you shortly.
Structure has taken shape in the heart of Lekki, one of the fastest growing communities in Lagos. Evercare Hospital Lekki is the largest private hospital in Lagos. A 165-bed, purpose-built, multi-specialty tertiary care hospital. Evercare Hospital Lekki offers high-quality and accessible healthcare across a range of specialties.
Evercare Hospital Lekki is a part of the Evercare Group, an integrated healthcare delivery platform investing in healthcare in emerging markets. Our vision at Evercare Hospital Lekki is to be the most trusted healthcare partner and preferred destination in Nigeria and the West African region, transforming the quality of healthcare and positively impacting lives across the region.
At Evercare Hospital Lekki, we are well positioned to address the gaps that exist in the Nigerian healthcare sector, and we aim to be at the forefront of advanced treatments in major clinical specialties. Our focus specialties are mother and child services, cardiac sciences, neurosciences, orthopedics, critical care and emergency medicine, amongst a range of other specialties. We have engaged a team of highly skilled and experienced full-time visiting consultants across subspecialties of medicine, surgery, pediatrics, obstetrics, and gynecology. A collaborative team approach to care will be promoted, continuously monitoring patient-reported outcome measures for optimal patient satisfaction and quality improvement.
As a purpose-built multi-specialty tertiary care hospital, our patients will receive comprehensive care that is efficient and thorough. Our infrastructure systems and services are designed to assist our physicians to deliver world-class services to patients.
At Evercare Hospital Lekki, we believe that every individual has the right to respectful and compassionate care as a patient. And we have introduced a framework for patient experience, encouraging each caregiver to treat every patient as they would their own family. Our caregivers are passionate about providing
So in about 10
patient-focused
minutes,
care,
we would
and this reflects in their attitude to the patient's overall experience.
be going
at
back
the
into the
hospital.
session.
We have been strategic in attracting the best talent locally and complementing their skill set with international experts to ensure a highly skilled, well-rounded, and diverse team.
Technology is critical to delivering
And,
high standards of healthcare.
We still have some more speakers, and after we take the speakers, then we would have lunch. So please relax and enjoy the program. Now, as I'm saying that we have 10 more minutes, the people at the back are telling me we have not eaten. No, just relax. It's just the queues. The queues are moving very fast. It'll get to you shortly. Okay? So in the next, say 10 minutes, I'll be back for us to continue from where we stopped. So please. You can go ahead with the Evercare video because I see a lot of us are interested in what is going on.
We'll have a multidisciplinary team of specialists to treat a wide range of cancers, supported by friendly and relaxing chemotherapy units for patients and relatives.
Evercare Hospital Dialysis Unit is managed by a team of highly experienced dialysis nurses, technicians, and nephrologists. The unit provides a welcoming, spacious atmosphere with individual entertainment units for patients to help pass the time. Affordable quality service is provided by strict adherence to guidelines and standard operating procedures.
The physiotherapy unit at Evercare Hospital provides the most comprehensive rehabilitation program for patients, particularly those with stroke, leg injuries, and pre- and post-surgery, giving them better quality of life.
Evercare Hospital has managed to attract highly talented group of nurses practicing in a dynamic environment to provide empathetic care. Our promise is to provide high-quality nursing care in a safe and comfortable environment.
We believe every individual has the right to respectful and compassionate care as a patient. And with the largest critical bed units in a private setting in Nigeria, we are well prepared to address the critical care needs of Nigerians.
Now, for those of us that have already finished eating or drinking, you don't need to stand up, just you could leave the plates on your table. There's an arrangement to help clear that up so that we don't prolong the break. The time is 12:49. In the next 5 minutes, we're going to continue. So by 12:54, we'll get back on track.
We look forward to embarking on our journey to transforming lives.
Welcome to Evercare Hospital, Lekki. This iconic structure has taken shape in the heart of Lekki, one of the fastest growing communities in Lagos. Evercare Hospital, Lekki is the largest private hospital in Lagos. A 165-bed, purpose-built, multi-specialty tertiary care hospital. Evercare Hospital, Lekki offers high-quality and accessible healthcare across a range of specialties.
Evercare Hospital Lekki is a part of the Evercare Group, an integrated healthcare delivery platform investing in healthcare in emerging markets. Our vision at Evercare Hospital Lekki is to be the most trusted healthcare partner and preferred destination in Nigeria and the West African region, transforming the quality of healthcare and positively impacting lives across the region.
At Evercare Hospital Lekki, we are well positioned to address the gaps that exist in the Nigerian healthcare sector, and we aim to be at the forefront of advanced treatments in major clinical specialties. Our focus specialties are mother and child services, cardiac sciences, neurosciences, orthopedics, critical care and emergency medicine, amongst a range of other specialties. We have engaged a team of highly skilled and experienced full-time visiting consultants across subspecialties of medicine, surgery, pediatrics, obstetrics, and gynecology. A collaborative team approach to care will be promoted, continuously monitoring patient-reported outcome measures for optimal patient satisfaction and quality improvement.
As a purpose-built multi-specialty tertiary care hospital, our patients will receive comprehensive care that is efficient and thorough. Our infrastructure systems and services are designed to assist our physicians to deliver world-class services to patients.
At Evercare Hospital Lekki, we believe that every individual has the right to respectful and compassionate care as a patient. And we have introduced a framework for patient experience, encouraging each caregiver to treat every patient as they would their own family. Our caregivers are passionate about providing patient-focused care, and this reflects in their attitude to the patient's overall experience at the hospital. We have been strategic in attracting the best talent locally and complementing their skill set with international experts to ensure a highly skilled, well-rounded, and diverse team.
Technology is critical to delivering high standards of healthcare. Evercare leverages advanced technology and state-of-the-art equipment to ensure desired clinical outcomes are achieved.
We are fully equipped and technologically advanced to cater for high-risk pregnancies and even the most fragile babies. An entire floor of the hospital has been dedicated to serving women and children.
Evercare Hospital has been designed to promote seamless patient flow and positive patient experience by positioning our entire daycare services physiotherapy, chemotherapy, endoscopy, and dialysis on one floor. Our endoscopy unit is equipped to investigate and treat the full range of pediatric and adult gastrointestinal diseases, including advanced endoscopic procedures.
At Evercare Hospital, we have a multidisciplinary team of specialists to treat a wide range of cancers, supported by friendly and relaxing chemotherapy units for patients and relatives.
Evercare Hospital Dialysis Unit is managed by a team of highly experienced dialysis nurses, technicians, and nephrologists. The unit provides a welcoming, spacious atmosphere with individual entertainment units for patients to help pass the time. Affordable quality service is provided by strict adherence to guidelines and standard operating procedures.
The physiotherapy unit at Evercare Hospital provides the most comprehensive rehabilitation program for patients, particularly those with stroke, nerve injuries, and pre- and post-surgery, giving them better quality of life.
Evercare Hospital has managed to attract highly talented group of nurses practicing in a dynamic environment to provide empathetic care. Our promise is to provide high-quality nursing care in a safe and comfortable environment.
We believe every individual has the right to respectful and compassionate care as a patient. And with the largest critical bed units in a private setting in Nigeria, we are well prepared to address the critical care needs of Nigerians.
Our in-house physicians, partnerships with Nigerian doctors in the diaspora, and doctors from Evercare Group will ensure that we have the capacity to provide treatments that many Nigerians seek abroad.
Quality is at the core of Evercare Hospital Lekki's healthcare mission. A robust clinical governance process has been implemented to ensure continuous quality improvement and the adherence to international standards for ethics and compliance. At Evercare, we will constantly innovate to ensure delivery of best-in-class standards of patient safety, clinical excellence, and outstanding clinical outcomes, with an unparalleled patient experience. With our dynamic and passionate team of caregivers, we look forward to embarking on our journey to transform lives.
Okay.
Welcome to Evercare Hospital.
Thank you very much. So please, let's settle down. We're going to be continuing right about now. All right, so even while we are, just for those of us that probably have not been able to approach the tea table, even while we are proceeding with the presentations, we could handle that business so that we save time. I understand time is of the essence. So, I'm going to be introducing our next speaker, and I would like to go through his profile. Dr. Arinzechukwu Mosanya is a highly skilled consultant general, a laparoscopic surgeon with a focus on various areas of surgical expertise. He holds impressive qualifications, including an MBBS from Nigeria, MRCS from Glasgow, and FWACS in general surgery. His focus areas include surgical oncology, specifically breast and colorectal, surgical gastrology, endoscopy, management of surgical infections, abdominal wall hernias and defects, as well as thyroid and endocrine surgery. With a wealth of experience, Dr. Mosanya has performed over 2,000 surgeries and procedures throughout his career. His surgical milestones include notable procedures such as rectal cancer resections, laparoscopic cloisterectomies, and breast-conserving surgery. Additionally, he has undergone extensive training and holds memberships in prestigious organizations such as the Fellow of West African College of Surgeons, the Royal College of Surgeons in Glasgow, the African Regional Group of Oncology for Oncology, as well as the Upper Gastrointestinal Surgical Society and its Endoscopy Steering Committee. showcasing his commitment to professional development and excellence in the field of surgery. Please join me make welcome our next speaker, Dr. Arinzechukwu Mosanya, as he comes up to take us further in this surgical colloquium. Please don't stop clapping till it comes up. Thank you very much. Thank you.
Good afternoon, everyone. Good afternoon to our listeners and viewers online. Okay, sorry, thank you. I hope everyone will still be able to listen to me as our attentions are directed to our plates. Interestingly, the topic I'm going to speak about today concerns what we eat also and how the body utilizes that. So I'm going to speak specifically on updates on bariatric surgery at Evercare Hospital, Lekki. This has been a topical issue in recent times because of the effect of globalization and changes in our health-seeking practices. And we are beginning to look at how obesity as a chronic illness is affecting our lives in general. And in Evercare Hospital, Lekki, where we pride ourselves in transforming healthcare and engendering surgical excellence, is one of our pillar specialties. And I'm glad to say that we've been able to kickstart that and want to present what we've been able to do so far and what lies ahead for us. So I'll be discussing on this brief outline, and I'll encourage you to follow me closely. Like I said earlier, obesity is now seen as a chronic illness, and by way of definition, it is a long-term positive energy balance where energy intake exceeds energy expenditure. Simple mathematics. When you eat something, you do some work. If you don't expend all that energy, the body has to find a way to store it. And this leads to this distribution of this fat, essentially, in organs. Fat on itself can be injurious, and inflammation of this fat then leads to those chronic illnesses that you can see associated with obesity. Worldwide, it has become a public health issue, and is estimated that about 650 people all over the world are obese. In Nigeria, the prevalence rate actually is about 27.6 for those who are overweight, and then 14.5 who are obese. And that's quite significant for a population of about 200 million. You can do the maths. Classification-wise, we'll use what we call the body mass index, which is when you divide the weight by a square of your height in meters. And if that figure is between 18.5 and 24.9, you are assessed to be your normal weight, or what we say a physiologic human. Anything above that, then you are heading towards obesity, and the various classifications are shown. So what does obesity lead in the body? Like I said, we are now seeing obesity as a chronic illness, and our trust in Evercare is to see bariatric surgery not just for the cosmesis, but as part of preventive health care. Because if you look at all these chronic illnesses and take your mind back, or think of anybody that you know that suffers any of this, and contrast that with the amount of money they spend to seek health care, the drugs, investigations, or even corrective surgeries that you do, such as your joint replacements or your cabbage for heart problems, or any of the other chronic illnesses. Take up somebody who has rheumatic, rheumatic arthritis or osteoarthritis. The amount of money they spend to seek health and the disability-adjusted life years that is lost from any of these chronic illnesses, you will agree with me that it's time we looked at obesity and bariatric surgery as part of preventive health. So obesity can virtually affect any system in the body. And these are the various things that can go wrong for somebody who is obese. Bariatric actually derived from two words, two Greek words. Baros means weight, and ekteros, which is medicine. So it generally just refers to those procedures that we do in the hospital to treat obesity and its complications. And someone will ask, why are you using surgery to treat obesity? Why can't the person lose weight by dieting or hitting the gym every day? Well, we now know that there are a subset of people that may not lose adequate weight no matter how much they diet. And there are also a subset of people that no matter how much you exercise, you won't lose that weight. And that's because studies have shown that surgery for weight loss remains the best approach for certain individuals, especially those who have chronic illnesses like diabetes and hypertension, as well as for the females who have polycystic ovarian syndrome and what have you. And is also the best approach for sustaining achievable significant weight loss, especially for those who may not be able to lose weight on their own. And compared to those who use non-bariatric means for weight loss and those who employ bariatric means for weight loss, those who have had bariatric surgery tend to have a longer disease-free survival and less mortality in the long run. Uptake of bariatric surgery has been increasing worldwide, and IFSO, which is the International Federation for Surgery of Obesity, estimates that almost 400,000 bariatric surgeries were done worldwide in 2018. Top on this list are US and Canada, which do about almost 260, down to United Kingdom. But if you look surprisingly at Nigerian figure, as published by Bariatric and Metabolic Surgery Society of Nigeria, just on the 1st of this month, we are barely doing about 214 bariatric surgeries a year, which is quite low, if you agree with me. And that's why Evercare Hospital Lekki is in the vanguard to popularize these procedures here in Lagos and to let people know that it's available and it's affordable and with good outcomes. So who are those that require bariatric surgery? IFSO and ASMBS have provided an updated indication for bariatric surgery as of 2022. Chief of that is anybody whose BMI is above 35, irrespective of whether you have comorbidities. You're a candidate for bariatric surgery. The indications become a bit cloudy when you are between 30 and 35. However, if within that BMI range, you have comorbidities like diabetes and hypertension that is worsening your health state, then you definitely qualify for bariatric surgery. And then any other person that is obese who require bariatric surgery to sustain their weight loss. So these are the indications. Definitely there will be, whenever there is an indication, there will be contraindications. So if you have any of these and you're obese, you may want to address them first before you undergo bariatric surgery. Untreated major depression and psychosis because of lack of insight and inability to adhere to some of the instructions that may be necessary to sustain your weight. You may need to have that evaluated by the psychologist or psychiatrist and have that sorted out. Current drug or alcohol abuse will negate adequate outcome following a bariatric surgery, and that may be one of the contraindications. And of course, if you have severe coagulopathy. So these are hospital and our facilities, and I just listed a few of our core competencies, of which you can see that bariatric and metabolic surgery is one of it, and that's why we are here today to discuss what we do, what we've done, and what we intend to do in the future. Our team was constituted earlier this year, and I would like to appreciate the management of Evercare Hospital for seeing that as a very important subspecialty to address. It's a very robust team. When Dr. Jimmy Coker was talking about procurement and inventory, they are very, very important people to be part of that too. And we realize that they've been quite supportive because getting some of the things that we need have been quite a challenge. And I would like to appreciate them for coming in today. Another unit that is not mentioned here is the care team, who are more or less not seen physically most of the time. You get to hear them over the phone, but they do a lot of the engagement with prospective patients, and I would like to appreciate them also. But all services and all subspecialties and professionals you can think of in a bariatric standard team are represented here, and I'd like to appreciate all of them for the work they've done so far and what we intend to do in the future. So we had our first cohort of surgeries in May. We had 3 patients, 1 male and 2 females, and this is a summary of their preoperative clinical data. All of them were in the severe obesity range. The lowest BMI was 45, while the highest was 60. They all have different desires in terms of percentage of their body weight they wanted to lose. And But of importance is the bolded statements, which are the numerous comorbidities that they came with us. Chief of them is depression, arthritis, sleep apnea, hypertension, prediabetes, and all of that. And they all had their surgeries laparoscopically. We had 2 sleeve gastrectomies and 1 laparoscopic gastric bypass surgery. Following our standardized and bespoke, I would like to say, Evercare Paediatric Program Clinical Pathway, which was developed in-house, but with consultation to establish guidelines from international bariatric societies. We pass them through this pathway where they have an initial evaluation, including clinical evaluation, where they have physical consultation and then follow up on virtual consultation. Here we assess their expectation, what is their motivation to lose weight, what are their comorbidities, what's their psychological makeup, are they motivated, can they withstand the stress of surgery, are they looking forward to sustain their weight, and if there are any impediments to any of these are adequately addressed. We investigate them to assess if there are any hidden abnormalities, hidden microdeficiencies, and then fitness for surgery as indicated. They all must pass through psychological assessment, and we have visiting psychologists, clinical psychologists, and those who have psychiatric disorders were also referred to be reviewed by the psychiatrist, and all of them were adequately managed. It's a must that they have a pre-anesthetic clinic visit where they are assessed for fitness for anesthesia. Nutritional assessment is sine qua non for any patient going for bariatric procedures because we want to know what their eating habits are, what their eating history is, what motivates them to eat, and what may be responsible for their being overweight. We also want to know what their initial body composition is because after surgery, we would like to follow up and know whether they are meeting up to set goals. Majority of them may have 1 or 2 micronutrient deficiencies that may not be apparent, and this must be corrected adequately. We commence them on what we call the liver reduction diet, which is a specialized meal plan that they should be on within the first week or 2 before surgery. And this essentially is to reduce as much free fat in their body as possible. This is designed by our in-house nutritionist, and it consists of 0 or very low carbohydrate, no free sugars, no refined sugars, high protein diet, and low fat. And the aim is to see if they can lose up to 5 to 10 kilograms of their body weight before surgery. The benefits of this include making the liver firmer because you need to, majority of them have hepatomegaly from hepatosteatosis. And during the surgery, you need to retract the liver. If the liver is that heavy, it can fracture during the surgery and can lead to catastrophic bleeding. So putting them on this so-called liver reduction diet helps the liver to be firmer and easier to manipulate during surgery. It also leads to better outcome following surgery as they are more motivated to lose weight, seeing that it is possible. So for the preoperative management proper, we usually admit them overnight. We put the thromboembolic deterrent stockings. These patients are overweight, and we know that obesity is a risk factor for VTE. We give them subclubclexane a night before the surgery to reduce the risk of thromboembolic phenomenon. We encourage ambulation and incentive spirometry. So you know that you come to the ward for surgery and you lie down on the bed. So we encourage them to walk around the ward, interact with other patients, keep themselves busy. Usually spirometry is started 2 weeks before surgery, and we intend that they do it every day and get used to the chest exercises. They can have a solid meal 8 hours before surgery. I would encourage them to take liberal clear fluids up to 4 hours before surgery. We'll give them a single dose of IV cefazolin at the pre-induction period. And for those who have penicillin allergy or are allergic to the cephalosporins, we give them IV ciprofloxacin. And we routinely don't catheterize these patients because most of these surgeries do not last up to 2 hours. So we encourage them to void just before induction of anesthesia. And this is also part of ERA's protocol. So we reduce morbidity of infection and early ambulation after surgery. Usually this is our position for laparoscopic surgery, is the split leg position with a slight reverse Trendelenburg and truncal flexion. So what this does is approximates the lower intestine, the small intestine, keeps it in the lower part of the tummy, of the abdomen, and frees the upper abdomen, which is where you do most of your bariatric gastric surgeries. And for those that are going to do bypass, it also brings the small bowel closer and makes your anastomosis tension-free. The surgeon stands in between the legs of the patient, sometimes on a pedestal, while the first assistant, usually the camera holder, is on the right, and the second assistant is on the left with the nurse also. It's good to have 2 monitors if you can afford that, so that nobody has neck pain during the surgery. And of course, we use general anesthesia with cuffed endotracheal tube. For access, we routinely use an optical port, which is shown on the right side of your screen. And this is usually inserted at the palmar point. Remember that these patients have a lot of anterior abdominal wall fat, which makes access a bit challenging. So you can't use your routine open access for that. So using the palmar point, which is just about a finger breadth or 2 finger breadths below the left costal margin, enables you to enter the space with a 5mm optical port, and you have direct vision into the peritoneal cavity. And of course, you can then place the other standard ports under direct vision. Notably, a liver retractor is put at the epigastrium to help to retract the liver. The key operative steps are outlined. First, we want to expose the left crux of the diaphragm and also prepare the cardia. This is very important so that you can know the insinuation of the lower esophagus into the stomach and guide you when you are preparing to staple the greater curvature. So after the fat pad around the left crux is removed, you need to dissect until you could see adequately the left crux of the diaphragm and the cardia of the stomach. So that's what is going on now using a ligature energy device. So after developing that, you can see that the surgeon's right hand is exposing the cardia and the distal esophagus as it enters the stomach. This is very important. If you don't do this at this stage, by the time you get to the fundus to staple your fundus, you may encounter some challenges. Next, the attention is now focused on the greater curvature of the stomach. 2 things are involved here. You want to separate the branches of the gastroepiploic artery, which supplies the greater curvature. And then secondly, you want to enter into the lesser sac to see the posterior surface of the stomach. Care should be taken here because most bleeding in laparoscopic gastric sleeve usually come from this angle. If you watch very closely, the surgeon is burning the vessels on 2 points, away and then close to the stomach. Remember that the blood supply comes from the gastroepiploic artery towards the stomach. So burning away from the stomach first catches the first bleeder, and then the second one closer to the stomach then separates. It's also very important that your dissection is done as close to the stomach as possible so that you do not damage the main arterial trunk, which supplies other vessels and other structures in the body. We continue the dissection from the incisura upwards along the greater curvature of the stomach towards the short gastric vessels as they arise from branches of the splenic artery. So walking towards the spleen, the piece of white gauze you can see there is to help you mark where your dissection should stop, which usually corresponds to the first branch of the short gastric vessels as they are approaching the esophagogastric junction. Now remember that I said that if you have removed that fat pad and dissected the left crux, by the time you get there, it's easy peasy for you because that completes your dissection. Having done that, you come towards the pylorus now and towards the duodenum, and you want to also cauterize the branches of the epiploic vessels. At this point in time, you will place a sizer tube, which we call a calibration tube. Usually it's a 32 French calibration tube, and which will help you to, if you arrange it towards the lesser curvature of the stomach, helps you to measure what the remnant stomach should be after you have done your sleeve gastrectomy. We'll apply the stapler device, which is a linear laparoscopic stapler, just hugging the calibration tube from about 4 centimeters from the pylorus so that you don't narrow that area, and you direct it towards the fundus. By the time you're approaching the fundus, it's also important that you do not leave a large remnant pouch, which can lead to some complications after surgery. If you're heading towards the fundus, then you angulate your stapling device towards the esophagus so that you have a very gentle tube. This is very important because if you leave a remnant, a too big a remnant stomach, there may be risk of volvulus or torsion at the end, and patient will have significant reflux. So here we have completed the sleeve gastrectomy, and the specimen has been kept to one side. Following SAGE's guideline, you must, or it is advised, following SAGE's guideline, to reinforce the anastomostic, your stapling end, with a running suture. This has been shown to reduce leak rate and also helps you to institute oral intake as quickly as possible. So we run a running suture with a 30 PDS of Vicry from the fundus, or the remnant of the fundus, towards the pylorus. And then when we get to the pylorus, we anchor the pylorus to the remnant greater omentum. This helps to maintain the natural dependency of that distal part of the stomach and reduces the risk of what I will say herniation of your sleeve gastrectomy, gastric sleeve into the esophagus, into the chest, which will also increase reflux symptoms following the surgery. Here we are concluding the running stitch on the staple line, and then we anchor the fat part there. Sorry, just a few minutes for the video to conclude. It's very important that throughout this process, your calibration tube is in place, because that's what helps you to maintain what your final size will be, and prevents you from stapling very close to the lesser curvature, which can lead to stricturing, narrowing, and also catastrophic bleeding. So here we are anchoring the dependent part of the sleeve to the fat pad so that it does not migrate and keeps it in place. And thereafter, we extract the specimen through the 15 millimeter port, which is usually at the umbilicus, or any of the other big ports that we use to insert the stapling device. And that's the specimen. So for sleeve gastrectomy, generally, we remove about 70 to 80% of the stomach, and you leave about a remnant 20% shaped like a tube. And that's all the person has for his stomach. And does two things for you. Removes where the stimulus for overeating comes from in the stomach, which is around the fundus and greater curvature, where ghrelin is produced, and then reduces the amount of food the person can take. So we've extracted the specimen now, and because it's a 15 millimeter port and 12 millimeter port, you must close the space to prevent herniation. And here we use a suture passer because of the increased fat pad and to reduce mobility of the patient. So we use a suture passer, and then we close the port to prevent a hernia. So in a nutshell, that's sleeve gastrectomy for us. We're hoping that we'll be able to present the bypass during the recorded videos on Saturday. So what was our operative summary, perioperative summary? So our patients did well. Average time of surgery was barely about 1 hour, 10 minutes. The first gastric sleeve was the fastest, 50 minutes, less than 1 hour. Second gastric sleeve was about 65 minutes. And the gastric bypass was 90 minutes. The only perioperative difficulty or complication we had was the first patient had some difficult intubation, which we eventually overcame. And they all did well and spent only 24 hours in the HDU before stepping down to the ward. They all started clear fluids on the night of surgery. And by the second day, they were taking diluted juices and started taking semi-solids by the third day of surgery, but none took solid meals until 1 week. They were, apart from the first person that had pneumonitis from the failed intubation, the difficult intubation, every one of them were discharged on the second day post-op, and he also eventually was discharged on the third day post-op. So we followed them up now for 3 months, and they are doing fantastically well. On the second row on the table is the expected weight loss following laparoscopic bariatric surgeries based on months after surgery. So on the first month, they're expected to lose about 8% of the starting weight, down to 22% at the 6th month. Now, it's pertinent to know that all of our patients have surpassed those expectations. And very interesting is the index patient, who has currently lost about 24% of his starting weight. And he has graciously sent us his before and after picture, which we'll see shortly. But thank you very much. But most importantly for me, as a budding bariatric surgeon, is the last column, which is where I'm very much passionate about, as most times the erroneous conception out there is that bariatric surgery is for cosmesis. But I'm one of those who see it as a preventative surgery, or more like using surgery to treat some chronic medical conditions. The first patient, when he first saw him, broke down in my clinic because he felt his life was worthless. It was somebody who had had major trauma, road traffic accident, was in coma for months, and after that, gained about 70 kilograms of weight within 6 months. And that greatly hampered his outlook. He couldn't wear clothes, he couldn't attend parties, and he went into severe depression. I'm glad to say that this guy now owns 2 successful businesses following this surgery, and he's doing very well. He couldn't play basketball because of arthritis and back pain. Now he's playing basketball, which he loves very well. And his sleep apnea has almost entirely disappeared. The third patient couldn't walk at all. She couldn't walk. She was being wheeled around by a wheelchair. Now she's walking with a walking stick and has resumed her catering businesses. So these are the things that we want to encourage and we want to propagate, that people should see this as a life-changing surgery, not just for the cosmetic aspect, which is erroneously being propagated out there. So this is Mr. X before surgery. He was weighing 167 kg. 3 months after surgery, he's weighing 127 kg and has lost 24% of his weight. So thus far, we've had additional trainings and collaboration with colleagues. I've had the opportunity of visiting my mentor and preceptor, Dr. Tahir, in Pakistan, where together we did about 12 bariatric procedures over a week. We keep developing on our engagements. We've participated in BSSN Congress in Abuja this year, where we also showed our experiences. I've had the opportunity to go to ICAD Kigali, where I met my mentor and he was one of our facilitators there, and we had excellent discussions and trainings on laparoscopy. And I would like to thank Medtronic, who are also here for graciously sponsoring that. We've also sustained our open houses. We had 2 open house sessions and we're planning for more. Also, we are planning for bariatric boot camps, which will be coming up very soon, mostly monthly or fortnight, where we'll have opportunity to address the audience and have an open sessions where people can come and ask any questions they want to know about bariatric surgery programs. It's pertinent to know that we've had more than 50 patient encounters so far, or prospective patients, and we are glad to announce that our second cohort is holding next week for another batch of bariatric surgeries. We now intend that this thing should happen on a very regular basis. Anybody can walk into Evercare and say, I want to have my bariatric surgery to treat my obesity, and you can have that done as quickly as possible. I will not be here speaking to all of you today without the help of great giants on whose shoulders I've stood. I would like to thank the management of Evercare for their support, especially the top level management. They've been very supportive. I would like to thank Dr. Tahir, who has been very passionate in helping Evercare Hospital Lekki to have a sustainable bariatric program. I'll thank my members in the bariatric team. Of course, it takes a village, as they say, to train a successful person. And I can use that corollary to talk about my bariatric surgery team. Some of them are here. You guys are wonderful. And keep supporting us and keep supporting our patients. I'd like to thank my teachers and mentors. Professor Adesa was mentioned severally today. I mean, without him, people like myself and Dr. Arua will probably not have the kind of exposure and mentorship and training that we had. Dr. Jimmy Koka, I first met him at Lason Inaugural Conference as a very young junior resident then, and that was where this thing started. almost 10 years ago now, sir. And I would like to thank you very much for solidly staying behind us. I'd like to thank our patients, because if they don't have confidence in us, we won't have a practice. And we'll keep encouraging them to keep on that patient. And then I'd like to thank my friends and family for all their support. And thank you all for listening to us today, and I'll be glad to take your questions. Thank you.
Thank you so much, Doc. Please put your hands together for it one more time. All right, so like I earlier said, there's a segment for question and answers, and we'll have that. But Doc, while you're here, I'd like to, at this juncture, invite all the speakers and all the members of the SLT would like to have a photograph with the keynote speaker, even at this point. So please put your hands together for them as they come forward. Let's take advantage of now where they are all here to have this photograph. We're going to have it down here. All right. Okay. So Chioma is going to help to organize us. And Toib, they will help us to organize us for the picture. And Toib will also be in the picture too. It's a very, very intelligent picture. So who's the photographer that they're going to be looking at? Okay. Okay, I'd like for the representative of from the Lagos State Ministry of Health to also join them. Please put your hands together for her. Thank you, Ma. Yes. Yes, finally. Thank you. Okay, she's also joining the other representative. Okay, we're looking at this camera, please. This one and this one. Thank you. Thank you very much. Please put your hands together for them. Thank you. So some questions have already been coming in. Like I said, we're going to have a question and answer segment after the next speakers. Then we'll take all questions together, sir. Thank you, sir. Wow. I don't know, Doc, is there, Dr. Arinzechukwu, is there any surgery that, we can gain weight with, Yes. I was just calculating that BMI. I said, my God, intervene. Please, Evercare, intervene for us, please. Thank you so much. So enlightening. Wow. All right, because of time, we'll go on. We just have about 2 more speakers before we start rounding off. How many of you have been learning so much so far? Anyone? Yes. Been so enlightening. I've been so, but for lack of better word, blessed. All right. Now the next speaker that is going to be coming up, I'm going to also read the speaker's citation. And I want us to, Dr. Ifedayo Adejare. He's a consultant urologist. Dr. Ifedayo Adejare is a highly experienced consultant urologist with a dedicated focus on various urology conditions and treatments. With over 20 years of experience in medical practice, he has spent 8 years specializing as a urologist. Dr. Adejare's clinical interests lie in benign prostate enlargement, prostate cancer, urethral reconstruction, andrology, and male factor infertility, showcasing a diverse range of expertise in the urological field. Since joining Evercare Hospital in Lekki, Lagos in February 2020, Dr. Adejare has further honed his skills through a 6-month subspecialty fellowship training in urology, with a specific focus on andrology at K Hospital in Hyderabad, India. He is known for his proficiency in performing minimally invasive urologic conditions, including procedures like bipolar TURP and laser treatment for kidney stones. Active in professional cycles, Dr. Adejare is a member of the Nigerian Association of Urologic Surgeons and the European Association of Urology, regularly participating in conferences and scientific meetings to present abstracts of his work. Personally, he's a family man married with 2 children. Please join me in make welcome Dr. Ifedayo Adejare as he comes up. Thank you, sir.
All right, thank you very much. At times I wonder whether that's me or someone else, but let's get going. So I want to thank everybody for attending this inaugural surgical colloquium. It's been a lot of work, and I want to thank the team who's put this together. I'll be talking about a part of urology that interests me a lot, which is how to treat kidney stones without making an incision in the patient. Now, in the past, you would have to make a big 10-centimeter incision to bring out a 1 or 2 centimeter stone. And then the patient would have to stay in the hospital 4 or 5 days, carry multiple tubes from their body, take multiple days of painkillers, occasionally have wound infections. Occasionally, they have hernias that require another operation. My esteemed senior colleague is here. He knows what I'm talking about. That's Dr. Ayo. So to be able to do the same treatment without making a single incision and having this patient go home maybe the next day, maybe 2 days afterwards, and practically go back to work. A patient can have surgery, possibly have surgery on Thursday and be back in the office on Monday with this technique for something that you required weeks of being away from work before. It's something great. So I'll be talking about flexible ureteroscopy and laser lithotripsy for renal and ureter calculi. Essentially how to break stones with laser. So, and that's my outline. It's also called retrograde intrarenal surgery. It's a surgical technique for accessing the collecting system of the kidney and the ureter. It has multiple synonyms. Now, it's been an evolution. The first time this operation was first thought about and designed was in 1964 by Marshall, and he used a ground glass fiber to look at a stone in the ureter. For those who don't know, the ureter is the tube that drains the kidney urine into the bladder. And he used an instrument that's 26 French. Now, 26 French is by 3, that's almost 9 millimeters in size. The size of our ureter is 3 mm. So this was a very big balloon ureter, not a normal ureter. And he was then able to see the stone, but he couldn't do anything, just visualizing the stone. Then the next step was when a much smaller instrument was designed, which was 13 French, which is just about between 3 to 4, about 4 millimeters in size. Again, bigger than most ureters. So this kind of instrument, you needed to widen the ureter to be able to even pass it in. And of course, that means you are damaging or potentially injuring the patient. So it never really caught on. But the first real modern stage came in the early 90s when Grasso and others reported a 7.5 French instrument that's about 2.5 millimeter wide instrument. So that was really the first modern instrument that could easily access the ureter. And it had a deflection at the tip of 120 degrees up and 170 degrees down, enabling you to look into the crannies of the kidney. And then, now the first real modern scope, the kind of scopes we use now, which have a 270-degree deflection. In other words, if you're looking straight ahead, you can essentially bend the scope to look backwards. Came into the market in 2001. And those are the kind of scopes we're using now. Let's go to how kidney stone forms. Because there are a lot of not doctors here, I will be very, very superficial with this topic. But what are the risk factors? Age. The older you are, the more likely you are to get stones. Sex, men more than women. Nutrition actually has to do with water intake, so I'm going to relate the two together. We know urine is a solution, right, from our basic chemistry. It has water, it has salts in it. Now, basically, urine is super saturated, meaning that it has more salts in it than it should be able to hold. And so there are things in the urine that help to keep the salts in solution. Now, if you don't drink enough water, then you make your urine more concentrated than it should be, and then easily salts can, crystallize out, and that's how stones easily form. I will quickly go to climate. People who live in hot and dry climate, like northern Nigeria. In northern Nigeria, there is a higher incidence of stone formation than in southern Nigeria because the climate is often hotter and drier than it is here. And there are genetic conditions, so inheritance plays a role in stone formation. Now, all these initial factors then go on to patients. If you have a kidney that doesn't look normal, is not able to drain urine properly, and then urine is not flowing. And when you have urine not flowing, stasis of urine can get infected, and those can then predispose to stone formation. Now, there are things like calcium levels in the in your urine. If they're too high, uric acid too high, lead to stone formation. Now, all these changes, all these factors need to what called nucleation, which is stones gathering together, and then the crystals can grow. And when crystals grow, you then get a stone, in a nutshell. No, let's just go here. So this here, let's see if the pointer is not working, but this first here is a small stone in the kidney of a patient during endoscopy. And this here is what's called a Randall's plaque, which is like a deposition of calcium under the lining of the kidney. Now, patients who have this would almost always form recurrent stones, and they are the kind of people you need to, educate on how to prevent stones from forming. Now, this is a much larger stone, but also demonstrates the same thing. This is a larger stone, and this here is where the stone formed initially in this patient, the Randall's plaque. So how do we do it here at Evercare? What's our technique? We have what we call endoscopes. Endoscopes are instruments you use to look into the body from outside through a natural orifice. In this case, we are examining the patient through their urethra, where they normally pee from. There are two types of endoscopes we use, rigid and flexible, to examine the bladder, 22 and 16 French. And then we have a ureterorhinoscope. That's the instrument that goes into, I'll use this. So this is the cystoscope. These are the cystoscope that goes into the bladder initially. And then this is the ureteral rhinoscope. Now, this instrument is extremely fragile. It's at the tip, it's 6.5 French. That's approximately 3 millimeters in its widest diameter. Now, this goes all the way from outside all the way to the kidney. And then we have this other instrument, which is the flexible scope. It's a very long instrument, about 150 cm long, and you can pass that all the way from outside the body, through the bladder, into the kidney to see the stones. And then we have additional instruments that we use. This is a light guide to transmit light so you can see. And then you then have cameras and a laser to break the stone. We also have a C-arm, which is an X-ray, and I'll show pictures of that we use to guide us while we're doing this operation. And then disposable supplies, which essentially costs a lot of money, increase the complexity and cost of this. We use catheters of various sizes, guide wires to enable us access, and stents, which enable us to drain from the kidney and when we finish. Okay. So this is us operating. This is actually from Evercare, and that's the surgeon there. That's me, and that's my nurse. And this is the trolley where all the instruments are kept. And that's the patient line. Those are the patient's legs, and the surgeon is in between the patient, and we have our X-ray there. And this is the anesthetist and their team, and this is our tower with our monitor and our light source. Now, this here shows the kind of specimen that we take out from a patient. Now, this is a ruler that you can see that this specimen, after breaking this stone, we get it to what, like 1 to 2 millimeter size. Now, that's what you want to achieve. So we're starting with a stone that's 1 centimeter, 2 centimeter. By the time you're done fragmenting it into dust, this is what you want to achieve. This kind of fragments will pass by themselves. They do not require removal, though we take 1 or 2 out for testing. So, what are the indications for this type of operation? 1, a stone in the upper ureter, stones that are bigger than 2 centimeters in size, or less than 2 centimeters in size, are the most ideal kind of stones for this type of surgery. Now, if a stone is bigger than 2 cm, it's preferable to do what's called a PCNL, which is to puncture the kidney from outside and then remove the fragment, bigger fragment. But you can then also do it endoscopically through the ureter. In that case, you have to stage the surgery. But when the stones are very big, you find that you tend to leave fragments behind. So how do we do it? We do a preoperative history and physical examination and do a CT scan, which enables us to identify where the stone is and the characteristics of the stone, how many there are. And then we do a urine culture to ensure that urine is clear of infection before surgery. This is very important because you don't want to operate patients who have infections. We check blood counts, we check kidney function, we check calcium, phosphate, uric acid, and depending on how old the patient is, we do chest X-ray and ECG. Now, if the patient is on medications to prevent clotting, they can't continue them, unlike most other open surgeries where they need to stop these medicines. If the patient has hypertension, diabetes, we have to have them well controlled prior to surgery. And then when we've done all this, we send the patient to the pre-anesthetic clinic to see the anesthesiologist. Now, what kind of anesthesia do we prefer? We prefer that the patient has a general anesthesia so that it's completely relaxed. Now, if the patient is under a general anesthesia, we can ask the anesthetist to stop them from breathing, and I will show it in the video how this is important during the case. And then we give antibiotics. I will position the patient as I demonstrated. Right, so when we've entered the kidney, we'll put an access sheet to enable urine to drain freely from the ureter as we're operating. And then we'll pass the scope, fragment the stone, and when we're done, we remove a fragment for testing and leave a double J stent. Post-operative care is usually very straightforward. Once you're done with the surgery, the patient is back to their room, and within a day or two, they're discharged home. First day after the operation, on the day of surgery, they usually have lunch or dinner, depending on what time you operated, and we'll remove the catheter that we'll place to drain urine. First day, we'll check their blood count, and if it's normal, we discharge the patient home. 2 to 4 weeks after surgery, we do a post-op x-ray to assess stone clearance, make sure we have removed all the stones, and then we remove the stent in the outpatient under local anesthesia. So how do we prevent complications? This is very important. The first step to preventing complications is to ensure that urine is sterile. No infections before you operate. Patients who have a UTI, antibiotics, and recheck that the urine is sterile before taking them to theater. If they're on anticoagulation, if it's endoscopic surgery, and they can't stop the anticoagulation, no vasoprene, warfarin, and the like, if it's not safe, then they continue with it because it doesn't affect outcomes. Otherwise, we'll stop it. Of course, if they have diabetes or hypertension, you've got to make sure that those are also well treated. And then intraoperative, we give antibiotics. There's a question as to whether you should put a stent in the ureter before the surgery or not. If the ureter, as you're examining the patient, if the ureter is wide, you just continue with your surgery. If the ureter is narrow, you put a stent, wait 2 weeks, makes the ureter wide, and makes the surgery very easy. It's good to have an x-ray, that's a CM, so that you can identify stones where they are. Access sheets, which enable fluid to drain while you're operating, you can place that if the ureter is wide enough. What you want to do is to achieve a low pressure in the kidney, less than 40 centimeters of water. Post-operatively, we've always put a stent to enable urine to drain. When we finish, we'll continue antibiotics. And really, when you've done these operations, you'll find that the patients don't need to go to a high level of monitoring post-op. They can stay in the post-anesthesia care unit and then from there move to the ward and then, second day or so after surgery, be discharged home. So this x-ray shows the patient who's had a stent placed. So this tube here, up here, is the upper end of the kidney, and here is the lower end in the bladder, and then the tube all the way in the ureter. So this is the stent that we placed after surgery. This is actually a post-operative x-ray of one of our patients, which shows that there were no residual stones. Right, so this is a video. Oh yeah, great. So this is a video of one of our procedures. This is a 44-year-old man with like a 1.5 centimeter stone. And that is a stent that we put there beforehand, and we're taking that stent out. And then we pass the semi-rigid ureteroscope through the urethra into the ureter. So this is like a 2-minute video of about 1.5 hour operation. All right, so that's going into the bladder. And then we were able to access the ureter. And that wire you see there is a guide wire. And then we finally passed the endoscope into the kidney, and I don't know how clear it is, but you can see a laser fiber, and this is the stone, and let me stay away from it. And what I'm doing at this point is to activate the laser fiber and break the stone into small bits in the kidney. And while we're doing that, we are flushing the kidney with water to enable us see what's going on clearly, and also to reduce temperature, because laser generates a lot of energy, and the water actually, when you're doing the operation, the water that is draining from the kidney, when you touch it, it's warm, almost warm enough for you to take a bath with. So when you're done, this is exiting the kidney. You can see all those particles. That's dust from the stone, right? Now, that's dust, and anything that's floating will come out by itself because it's essentially like dust. I mean, when air blows, it carries a lot of dust. Same thing with water. Water is able to carry dust. So the urine just drains all this out. And what usually will happen is that in the first few hours after surgery, when the patient goes to pee, all they will be peeing out will be this very dusty urine. And then that's the end of the operation. Now, what are the challenges you would face if you want to start this kind of program where you are? You're going to have to train your staff because preventing cross-infection is extremely important. Looking after these very fragile, very expensive instruments. It's there. Obtaining consumables. Igwe is here. I bother them a lot. And the cost of the consumables. And if you want to do a standard practice, what is single use must remain single use. That increases the cost, but you buy that back because your patients don't get infections, they don't spend money treating horrible bacteria, they don't stay long in hospital. So even though you spend a lot of money on consumables, you save the patients from terrible complications. Now, training is extremely important. And I'm not just talking about training the physician, but the physician who is performing the surgery, working together with the anesthetist and the perioperative nurse and other members of the team to ensure good outcomes. Your perioperative nurses will be looking after this instrument. You have to engage them, teach, and get them trained. Otherwise, your very expensive flexible scope will break. And these are extremely I think our store's scope is well in excess of 9, if I'm allowed to say, well in excess of 9 million, that flexible ureterorenal scope. So, the final bit of challenge is equipment downtime. In advanced markets, when your equipment, because these instruments will break down eventually when you use them, whether or not you're careful, they will eventually break. And when in advanced markets, when you have equipment breakdown, you just contact your vendor, they take it away for repair, they give you another one. But Eric is here and he knows how we've struggled when this has happened. Everybody who is aware of it knows the kind of struggles we face. So those are the kind of challenges you will face when we're setting this up. To conclude, I would say that IRS is the mainstay of kidney stone surgery. I'm pretty certain nobody is ever going back to making a big incision to bring stones out anymore. Yes, it's expensive to get started. It's challenging, but it's extremely rewarding to be able to treat patients without having to make any incisions. Looking around the room, I can see a few people that have helped me to get this going. A representative of the perioperative nurse. I'll mention names. I will. Yeah, Mokwe is there. right? She used to assist me before at surgery, but she ran away to cardiac. That's fine. But, but there are other members of the team that work with me. None of them is here presently. And we all started from scratch. And they're all extremely proficient now. I don't get involved with the instruments anymore because they know what to do and they do it properly all the time. I can't say anybody from anesthesia, but anesthetists are extremely important. You can't do this surgery properly without an anesthetist who works with you and understands what you want. The care team as well, who interface with our patients. Felicia, thank you. Without you, the patients don't get to surgery. Management, because when instruments break down, we are breathing down their necks to help us fix things. Adejare, because you guys don't fail to supply all the consumables. And there's also the whole front, without which I can't function, because I like to operate and I go home at odd hours all the time. So thank you. Okay, thank you everybody. Questions, comments?
Please a round of applause one more time for Dr. Ifedayo. Now, I was also told that Dr. Ifedayo will be performing a live surgery on day 3 of this program. Wow, so we get to see it live. Please put your hands together for Dr. Ifedayo. Amazing. See, I said it as if it was a movie. We get to see it live. Amazing. Okay. We'll be going on. I mean, I want you to put your hands together for the organizers because we're right on time. You know? Put your hands together for me too because, I mean, okay. Please bring it for me. Bring it for me. Thank you. The next speaker coming up is actually our final speaker. Now, after this speaker, we would have the question and answer segment, and I'm sure a lot of us have a lot of questions for all the speakers that have come up thus far. So we're going to open the floor. We're going to read some questions that have already been sent via the YouTube platform, directed at various speakers who would ask those questions after the speaker. So I'm going to introduce the next speaker now. I'd like if his profile could be on the screen. We have Dr. Temitope Akinola. Dr. Temitope Akinola is an esteemed obstetrics and gynecology specialist focusing on fetal-maternal medicine, reproductive endocrinology, infertility, and general gynecology. With a track record of over 1,000 successful cesarean sections and more than 600 surgeries for uterine fibroids, he has demonstrated exceptional clinical skills and expertise in the field. Dr. Akinola's commitment to professional growth is highlighted by his accolades, including the Chevron Undergraduate Scholarship, National Merit Category, and his role as a certified family planning trainer by USAID and Marie Stopes International. He's a fellow of the West African College of Surgeons. In addition to his clinical achievements, Dr. Akinola has held key positions at reputable medical institutions such as Premier Specialist Hospital VI and Oriental General Hospital in Riyadh, Saudi Arabia. He's an active member of prominent medical associations like the Association for Fertility and Reproductive Health and the Society of Gynaecology and Obstetrics of Nigeria, showcasing his dedication to advancing women's health care on a national and international scale. Especially the ladies, I want you to make welcome Dr. Temitope Akinola as he comes up. Especially, is their doc.
Thank you very much. Okay. Thank you very much. It's a great opportunity to share in one's area of expertise. I want to appreciate the senior leadership team of Evercare Hospital, Dr. Ayo Shonibare, who is the pioneer of this vision to transform healthcare in Nigeria, the Chief Operating Officer, Mr. Herrick, and other members. And I also want to appreciate all the people who I've had to collaborate with since joining Evercare Hospital, first as a visiting consultant in May 2021, then as a full-time consultant gynecologist, September 1, 2021. It's been a great experience working with highly committed perioperative nurses, anesthetists, pharmacists, and the whole thing in general. I'm presenting on behalf of I'm representing Dr. Olashukwu Mogunja, who is the lead gynecologist for the team. The OB-GYN team in Evercare Hospital is a robust team of 5 full-time consultant gynecologists with some visiting gynecologists, and all of us have our different interests, trying to encourage subspecialty focus, both in terms of service and training. Now, I'll be presenting conservative surgical management of humongous fibroids, case presentations, and challenges. Now, why this topic? The reason is because a lot of people are actually amazed at the kind of presentation we have in Evercare Hospital when it comes to fibroids. Now, fibroids, like we know, they are benign tumors of the uterus, and they represent the most common benign gynecological condition in women. Now, I must say that more than 60% of our surgeries are due to, gynecological surgeries are due to fibroids. Now, why is that so? Well, people have tried to find out why is there high prevalence of uterine fibroids. Until now, what people talk about are theories in terms of risk factors. So nobody can exactly say what causes uterine fibroids. But what's actually very important is genetics tend to play a leading role. Black race, delaying childbirth is becoming an emerging role. The evidence for diet is very, very weak. We do not have enough robust clinical evidence to say diet is contribution towards the menace of uterine fibroids. Now, I started this by just showing you the kind of fibroids we are seeing. Now, the kind of fibroids we are seeing here in Lagos are not the ones, or let me say majority of them are not the ones that will benefit from minimal access surgery. Now, why is this so? You may be, I remember when this particular case we did, this is not actually not the biggest we have done, but this is just one of the ones we do, is that this 3.3 kilogram fibroid, a lot of people will be wondering and finding out, why is this woman, why did she wait to get this big? That's the first question that comes to your mind. But let me give you a shocker. This patient never had heavy menstrual bleeding. This patient never had any symptoms. This patient just knew that she always had an abdominal torso. She knew that she had tummy, and she thought it was actually due to her weight. She never had dysmenorrhea. She never had heavy menstrual bleeding. And this was just found when she went for a routine ultrasonography to find out that she had something. The sonographer never believed she had something this big. Now, the lesson in that is that fibroid presentation, the size does not correlate with the presentation. You can have a patient with this large size of fibroids. If the location is not submucous, she won't have heavy menstrual bleeding. And somebody else will have a very small fibroid, but because of the location and because it's submucosal, that kind of patient has been having heavy menstrual bleeding, and such a patient may have to actually present earlier than this particular one. Now, well, this is just to whet our appetite. I will go on later on to show the video section. Of course, there are other pictures just for us to see the kind of masses that we are seeing in Evercare Hospital. Now, this is just an overview of our statistics. Now, I must say that this was as at April 2024, based on what we can get from the HIS. We've actually done more than this. Now, if you look at this, when it comes to mammectomies and hysterectomies, you find out that a total of over 160-something surgeries. Now, the commonest indication for these are surgeries have actually been uterine fibroids. Now, for the laparoscopic surgeries, Dr. Lashukwu is actually the lead laparoscopic gynecologist we have. He's done 23. Now, 3 of them were laparoscopic assisted vaginal hysterectomies. He's done some lap sapingectomies, lap cystectomies. We've not done any laparoscopic mammectomy. Now, why is this so? One of the criteria for laparoscopic mammectomy is that the patient selection criteria is that the uterine size must be less than 14 weeks. Now, the individual size of the fibrous, no uterine fibroid must be more than 6 centimeters. You must not have a myoma near the uterine artery. So you find that most of the patients we do have, whether the ones that are very symptomatic with heavy menstrual bleeding who come to the ER with life-threatening menorrhagia, or the one who's just found on routine ultrasonography, have uterine sizes, huge abdominal pelvic masses, equivalent to patients with like an 8 months pregnancy or 9 months pregnancy. These are patients that have been actually taunted by people that, oh, you are pregnant, and people keep asking them, when are you going to deliver, not knowing that the patient is actually harboring a very huge myoma. Okay, this is a clip of lap hysterectomy done. Now, when we use the word gigantic or enormous, colossal and mammoth, those are the kind of fibroids we see in Evercare Hospital. Now, I must say this. There's been a lot of negative, or let me say, bad press or bad media perception about fibroid surgeries. Potentially, people believe, or let me say, they see fibroid surgery like a death sentence or something very, very life-threatening to do. But I must say that we've done over 160 surgeries since inception for fibroid, and we have not lost a single patient, to the glory of God. Now, I must say that the question is this: are we still going to keep seeing this kind of large myomas? Yes. We practice in an environment whereby a lot of women are now, there's a high premium on career development. People are delaying childbirth. As long as childbirth is being delayed, that has actually been a recurring decimal for uterine fibroids. In terms of saying what is the exact etiology, that has not been proven. But delaying childbirth has actually become the common denominator to the kind of uterine fibroids we must see. Now, I must put a corollary to that. We are also seeing worrisome trends of some of these large myomas, 27-year-olds, 26-year-olds, 28-year-olds. Now, that tends to negate what I was seeing in the teaching hospital. In the government hospital, what we normally saw was that before you see fibroids get this big, women would have delayed childbirth for 10, 15 years. And that used to actually be a reason why a lot of times where you see gynecologists being wary of operating fibroids in young women who are not trying to start procreation. Because the worry is that if you remove the fibroids too early, and the patient doesn't try to get pregnant in 6, 7, 8 years, she's going to have a recurrence, and that patient is going to have a repeat mammectomy. So we are also, not only are we seeing very huge myomas, we are also seeing them in women. 27, 28 is not really practically something you consider too late to start a family. But we are seeing that also in young women. So there's a need for actually to still look at the epidemiology of uterine fibroid and actually to look at what these risk factors will be. And I think a lot of these answers will be provided by molecular biology, because it's now looking more of molecular analysis, looking at role of chromosomal translocations, role of cytokines. Are there things genetically to actually explain the kind of fibroids we have? Now, let me also add that we are getting a lot of referrals, even from people outside the country. We have one of the largest one I did personally since getting to Evercare Hospital was a patient with a 32-week size fibroid, almost similar to this one I showed you, who actually went for 2 different opinions in the US and the UK. And because of the size of the fibroids, they offered a total hysterectomy, irrespective of the fact that she was nulliparous. Now, this was a big decision for her because she wanted more children, and the goal, what she wanted was to have the myoma removed and planned to have an IVF after. But of course, she went both to the US and the UK, and they said, well, it's going to be quite risky to do because they both offered hysterectomy. This particular patient came to Evercare Hospital. In the year 2022, we successfully did an abdominal myomectomy for this patient, and she has actually gone for a IVF after this. Now, so that's to let us know that we are getting a lot of markets, not only nationally, we're also getting internationally. We're also getting from patients who are on a long waiting list outside the country. People with 9 months appointment, a year appointment to see a gynaecologist. And sometimes some of these masses are very big, it will even be referred from a general gynecologist to a gynaecologist by virtue of the size of the mass. Now, I'm going to start. I want to show us part of the challenges we have. Why do people dread having fibroid surgeries? One of the major worry is that is blood loss at surgery. We have been able to develop measures of reducing blood loss during myomectomy. Part of this is actually to choose when you operate your patient, who to operate, and when to operate. So the timing of the menstrual cycle is very important. Okay, in optimizing their packed cell volume before the surgery, and this emphasizes the need for a thorough anesthetic review to ensure that the patients are fit. Because some of the bad press or negative media issues about, oh, somebody did my fibroid surgery somewhere and died, some of them may actually be due to the fact that patient had a pre-existing medical condition, which makes such a patient going on anesthesia a huge surgical risk. For example, there was no way we could do this kind of fibroid under regional. We actually did this patient under general anesthesia. Duration of surgery was less than 2 hours. We were very lucky that as big as this myoma was, it was actually more of a fundal subserous fibroid that had actually gotten blood supply from the omentum and the peritoneum. So it was, in fact, I wanted to see whether we could show you what, we've sent this for histology because this surgery was done yesterday, but I wanted to see whether I can show you the remnant of what the uterus was after the surgery. This is the myoma we're trying to manipulate. Of course, she had an extensive midline incision. Now, down there, is still the uterus. There's a vascular pedicle beneath that subserous myoma. Now, she was very, very lucky because the fallopian tubes and the ovary on both sides were normal looking. So we're not really worried. And she never had any submucous myoma. Because one major issue that keeps coming up is that people are worried about procreation. This patient is 40 years old and she's still nulliparous. So this is not a patient that will accept anybody to do an hysterectomy for her. Now, I must tell you that in doing this surgery, I also took a double consent for hysterectomy because you must never, when they come with all these large myomas, huge myomas, they come because they believe the skill for open gynecological surgeries is in Africa. They come with very great expectations that, oh, you can remove the myoma, keep the uterus, for them to try childbearing. That's what they want. But you as a surgeon cannot predict what you will find in there. You may have to eventually remove the uterus to save the life of the patient. There are some instances whereby if there are multiple intramural myomas and you are carried away about removing all the myomas, you leave a tissue, you leave a uterus that is actually devascularized, that is not capable of future reproductive function. So one must not get carried away. In Africa, it's a cultural thing, expectation about keeping your womb. Even women who have had 2 parous experiences with fibroids, that you expect them to give consent for total removal of the uterus. They say no. You ask them, do you want to try to have more children? They say no, but I believe that I should go back to my creator the way I came. So people have an issue or reluctance to have an hysterectomy done. So the consent must also involve a double consent for hysterectomy, because by the time you have to make that decision, the patient will be under general anesthesia, and sometimes you may also have enough legal representative to witness that consent, because some of our patients, they look at the outcome to justify what they said. The same patient who is unwilling to give you a consent, especially for the repeat myomectomies, which carries a high risk of bleeding. The same patient who is reluctant and telling you that, oh, doctor, please, I want to preserve this womb because I want to try for procreation. If anything goes wrong, the patient will still say you should have done an hysterectomy to save the life of the patient. So you must be able to commit them, and the surgical consent must be very, very explicit on that. Now, I want to also give us an example of a patient that was referred from another hospital. This is just showing us the kind of, like I told you, most of them, when they walk around, people call them Mama Beji, you know, you are carrying twins, carrying triplets, you know, people don't know what they are going through. This is not a pregnancy. This is just one of the several types we see. Yeah, and why do they come to Evercare Hospital? When it gets this big, everybody knows that it is potentially like life-threatening. So they feel more comfortable to come to us in Evercare to have these surgeries done because of the risk involved, and also because they know they can get the multi-specialty collaboration when they come to Evercare Hospital. Now, I also want to talk about a 37-year-old Laparoscopic patient who had large uterine fibroids, but who was operated elsewhere. The patient was not originally operated at Evercare, but was brought to us with major post-surgical complications of generalized sepsis with uterine gangrene. The patient presented in a delirious state with fever, tachycardia, and hypercapnia. Now, I'm going to show us, this was the picture of the uterus of a patient that had a myomectomy done elsewhere. Now, so Evercare Hospital, we are also becoming like a referral center from private hospitals, like a private teaching hospital. And now, the learning point in this case is, the surgeon actually, there were a lot of fibroid nodules he enucleated, but the patient had uterine gangrene. So it's not just about removing myomas and say, oh, I brought a 3.5 kilogram myoma, or 3.5, or 87 nodules, 76 nodules. It's about, are you leaving behind a womb that is capable of future reproductive potential? Because that's the overall aim of myomectomy. If you cannot do that, then it's better off removing the uterus to save the life of the patient. So what could have actually gone wrong, despite the fact that the referring surgeon did a lot of enormous work in this patient? Now, one possible thing that could have gone wrong was that the surgeon could have actually left the uterine tourniquet for more than an hour or 1 hour 30 minutes. We normally use a Foley's catheter as a tourniquet at the cervicoisthmic region to actually reduce blood supply during myomectomies. Now, there are instances whereby if you have a huge cervical fibroid, sometimes it becomes very difficult for you to use that. And sometimes we complement the use of that tourniquet with the use of intralesional vasopressin, which is available in Evercare hospitals for reducing blood loss. But while using the tourniquet, you must, in fact, we announce the tourniquet time. The nurses will note that, because they know that if you leave that tourniquet and you are enjoying the myomectomy, you are enucleating the nodules, and you are not thinking about repair or the restoration of the blood supply of the uterus, you are going to leave a uterus that will have uterine gangrene. Now, the gangrene will not be very obvious on your table, okay? It's actually after presentation, when the patient post-operatively, that these things may become very obvious. Of course, with uterine gangrene, things like sepsis will come in, which will progress to things like septic shock and multi-organ dysfunction syndrome. So the learning point there is that myomectomies may appear, oh, they are being done in a lot of places, but it's about doing it properly well and being mindful of the fact that the final solution to a myoma, that can prevent the recurrence of a myoma, is when the womb has been removed. But since we live in an environment that holds a high premium towards the use of, towards keeping their womb, we cannot shy away from the fact that we are still going to have patients who will come requiring preservation of the uterus. Okay, these are things I highlighted about what could have gone wrong, prolonged use of the tourniquet and things like that. Please let me let me end by saying that surgery for fibroids does not rule out the role of alternatives. We have a visiting interventional radiologist to Evercare Hospital, Dr. Ahmed Nolowo, who does ultra-artery embolization for some of our patients who may require it. So it is not about one cap fits all for uterine fibroids. When a patient comes to the hospital, we run a specialized fibroid clinic in the Evercare Hospital at the OB-GYN department. And we want to make patients realize that it's not about we operate all patients. Not all patients will require an abdominal myomectomy. Not all patients will require an hysterectomy. Some patients may benefit from ultra-artery embolization. Some patients may benefit from high-intensity focused ultrasound, which is not available here, but available in Lagos. Some patients may even benefit from conservative management. So our patients should trust us to believe that in deciding on which particular surgical modality is for your treatment, we will give you options of treatment, and we will also be considerate of things like your desire for future childbearing or procreation, which is a very common topic that comes into mind when talking about uterine fibroids. Thank you very much.
Wow. Thank you so much, Doc, for that amazing session. Like I earlier promised, we're going to be having the question and answer segment right about now. And I know because of Nigerians would like somebody to open the floor with questions first. So I'm going to take one question here from our online viewers. I don't know if I could be assisted with this second mic. Can any of the ushers come? Thank you. All right. So I'll take one question from those that are watching online, and then I'll also open the floor here for those of us that have questions for any of the speakers. You could ask your question. And those of you online too, please feel free to just put your questions in the comment section, and we'll take as much as we can in the window that we have. Okay. So this particular question now is for Dr. Arua Igwe. It says, sir, this is from Abdul Hafiz Adesukomi. He says, sir, are there opportunities for pediatric surgical trainee to do some training under your tutelage, especially in the field of pediatric laparoscopic training, which is new? Where's the usher, please? Please, let's give it to Dr. Arua to kindly answer.
Okay, thank you so much for the question. So one of the things that we want, one of the reasons why we organized this program, thanks to the management of Evercare Hospital, is to start showcasing that we can actually be training other surgeons or aspiring surgeons to do what's showcased here today. And one of the things we are doing tomorrow is the workshop, dry lab workshop, and also showcasing live surgeries on Saturday morning. So that's also part of training. And this is just the beginning. So once this has taken full shape and we have kicked it off properly, then to be an avenue to have more aspiring, minimally invasive surgeons to come and have training with us. Okay. Thank you.
Thank you very much, sir. Thank you. So I believe that is clear. I believe, Abdul Hafiz, you would like to be in the dry lab workshop session tomorrow by 9 a.m. at LUTH. And also day 3 when we have the live surgeries. These are very interesting expositions. Okay, wow. We have a representative from Lagos State Ministry of Health has a question. Please, can we give her the mic? Thank you very much, ma'am.
Thank you very much, Evercare, for doing this surgical colloquium. In fairness, I came here with an expectation, but you surpassed my expectation. Please, another round of applause to the management. With the accident report or history of Professor, I'll call him Professor Shonibare. He has been in that field so far to ensure we can turn things around. And these are the people that have seen the four walls of the world, I'll call it. Now they are bringing it back to us. And that is why you find most of the younger ones that are living. You find the younger ones, Nigerians especially, I won't say Africa, Nigerians taking the lead. Most of my friends from Ife, they are the HODs in most of the universities in Canada, surprisingly. And that's, I need to tell you that we are what it takes. So this mentoring, I would want to know, is it institutional-based or according to an individual? I ask because it involves some money. This is management question, though. It involves some money because to mentor somebody, you have to take him through the skills, the hands-on skills. And these are, just like the second to last presenter, these are the instruments that are not easy to get. You spend a lot. So I would like to know what the cost is like. Or is it free? Because when things are free, you don't know the value. However, I'd like to also ask, by virtue of my position prior to this time, like I introduced, I'm a nurse, but I serve in the capacity of the president of West African Postgraduate College of Nurses. And during that period, I could see the engagement of nurses and doctors. But in the African setting, ECOWAS is trying to do something to bring all the Anglophone, Francophone, and Lusophone together. We find that the Anglophone are usually ahead of, in terms of training, in terms of exposure, and is putting all other regions at the bay. But recently, we had a meeting, and we are having another regional meeting soon. We are trying to see how these other countries can also increase their capacity. So are you thinking in that line? Because I could see you, I don't see you in the next 2-3 years in this same state. I see you going beyond. I see you going beyond because your focus, and by the way you kept the time today, it gives me ample opportunity to tell you that you are going to make it beyond those that have been existing. So are you thinking of co-opting other African countries and possibly the sub-region that I just mentioned? Thank you.
Wow, okay. So that question is going to be directed to, said it's a management question. So who, okay, Dr. Ayo is going to help us. Please put your hands together for Dr. Ayo as he responds to those numerous questions.
Thank you very much. Those are solid questions. I think, I must thank the organizers. I must thank everybody present and our business and marketing unit. I'm actually excited by this meeting. This is the first one. And with anything that one does, if the first doesn't go well, then you kind of struggle. So there's a lot we're going to build from this, and even with the contributions that we're getting, to incorporate that into the next step. So to answer those questions, mentoring, we already have something in mind that we're working on. We're going to start residency program at Evercare. Now, the idea behind that is we need to expose the younger ones to advanced care delivery. Not only that, we will be partnering with public hospitals. We've already we sent MOU to LUTH. The idea is that other public hospitals that want to be part of this, LUTH, even Ife, I mean, from the products Ife has given us, we need to give something back to them. So really, I think this is the beginning. After this, we're going to start planning next step. We want junior residents to come into the hospital. It's likely to be almost free. So because you asked that question, we're not looking at the money, we're looking at building capacity. So this is something that we're passionate about, and we will definitely move in that direction. The second question that you asked about other African countries, there's something happening now. There's something called AFCON, where there's supposed to be free movement and trade between the African countries. Almost all the countries in Africa is signed up, including Nigeria. Implementation is now what is holding or slowing the process down. And what the various governments are working on now is ease of movement. Because right now, to still get a visa, if you want to go to some of the African countries, like South Africa and all these other, is still a problem, a challenge. So the governments are talking to each other for people to be able to move back and forth. Of course, as that is taking place, then we can begin to collaborate with all the other hospitals around the African countries and begin to expose and build the capacity.
Thank you very much. There's a hand at the back. Can we get, actually 2 hands. And there is one here. Okay, so we take you, then we take those 2 at the back.
Good afternoon, everybody. I want to thank Evercare for this forum. I was a patient in Evercare February for kidney stone surgery, and it was handled by Dr. Ifedayo. I want to thank God that I'm fine, I'm just perfect. I got my life back. And it was very scary at first because I had a physical surgery that they actually inside and they did not see the stone. And I had to do another one again. So it was phenomenal. I'm just happy that I'm alive, I'm well.
Wow.
So about fibroids, I had a fibroid operation, I think about 10 years ago. And it's as if I started having another discomfort and went for a scan and they say fibroid. So I want to find out why is it that it reoccurs and what can prevent it.
I believe that question will be for Dr. Temitope.
Thank you so much. Like so many other conditions in women, there are a lot about trying fibroids is not known. Okay? There have been theories, or I would say risk factors. Why do fibroids recur? People have suggested about the constant exposure to estrogen. As a woman, as long as you are still within the reproductive age group and you are not yet menopausal, the fact that you have estrogen running in you, estrogens will actually stimulate the growth of fibroids. Now, there have also been a lot of controversies against that theory because we've had to also remove or do hysterectomy, do hysterectomies for large fibroids in post-menopausal women who were not really symptomatic before they became menopausal. So to let you know that it's not just about the hormone alone, and people are now looking at other things. I talk about genetics and things like that. So the guiding rule is that if you had fibroid surgery done, removal of the fibroids, if you do not have pregnancies or you're not planning to get pregnant in between, as long as you are still premenopausal, there's a likelihood for it to grow back. And that's why we are always very, very careful in deciding to operate fibroids in young women who are not yet ready to start getting pregnant. Because if you do a mammectomy for a 27, 28-year-old woman and she's still facing career, she has other things to do, and she's not getting pregnant 7, 8 years after, there's a likelihood that there will be recurrence. Okay? And you now have to do a repeat mammectomy. And most of the bad stories about mammectomies people hear out there, they are usually repeat mammectomies. Repeat mammectomies carry a lot of risk. So fibroids can always regrow unless the uterus, the womb is removed. And that's why the definitive surgery or the definitive solution is when the womb is removed. And that's why you won't blame some of our colleagues in the Western world who would do hysterectomies even for nulliparous, for women who have never had a baby before. But that kind of a practice, if you do it in this environment, if you have a reputation for just offering everybody hysterectomy once you have a large fibroid, it's going to affect, because that's not what people want. There's a high premium on childbearing in these environments. So that's about that.
Thank you very much. All right, so we're going to take the questions at the back. Thank you so much for your question, live testifier, amazing. All right, so I see 2 hands at the back. Okay, so please tell us your name, all right, and then ask your question. Who you're directing your question to also. Thank you.
Good afternoon, everyone. My name is Olalere Abdulmalik Kayode, 400 level medical student at Lagos State University College of Medicine. So I want to first of all thank Evercare for giving me and my colleagues the opportunity to be able to witness this and to see beyond the 4 walls of the General Hospital and the opportunity beyond. So my question is actually directed to all the speakers. Wow. And I would really appreciate if they can expatiate based on we are novice and students.
As
and
one
how best
stone
to
to kill multiple birds. Wow. Go ahead.
Anyone, actually. So there are 2 questions. My first question is, I don't know, maybe I didn't listen properly, but all through the presentation of laparoscopy, we didn't properly understand. I didn't really hear the main maybe complications or side effect or the downside of this procedure, because when we are propagating this, these are what people will try to ask from us, because it's most likely in 1 in 10 people, that will be maybe the first time they'll be hearing about it. So what can any of the speakers expatiate on this? Then secondly, I want to know if so far in the progress of laparoscopy, has there been any maybe subdivision or subspecialty in which you don't need to go through the whole of residency and you can just learn a skill, or maybe you just need to learn 2 years something. I'm just asking if it is available, or as that now we still have to go through the whole 6 years of residency before you can do something like that.
My brother is finding a way out. He's looking for the way out. Okay, and which of our speakers would like to answer his first question concerning the potential side effects or downsides of... Okay, thank you so much, sir. Dr. Arinzechukwu is going to help with that.
Okay, thank you very much. I believe you're asking about complications, right? And downsides. Just like any other surgical procedure, you can classify the classifications as intraoperative and post-operative, right? So for intraoperative, some of the complications are due to the access. So if you are getting access for laparoscopic surgery, the placement of your trocars, you have to be very careful with them so that you don't injure the vessels or the other structures inside the abdomen. So that's why as a beginner, you'll be asked to place your ports in an open manner, meaning you dissect through a small hole until you are sure you're in the peritoneal cavity before you put in your scope. Then as your proficiency increases, you can then go to the things like using Veress needle, and right now almost everybody uses the optical port. So the optical port is transparent. You put a camera into the hole, and as you are going in, you are looking at the tissues as they are passing through them. So that greatly reduces the risk of injury. But by far, some of the potentially devastating complications had to do with the pneumoperitoneum. So when you put gas in the abdomen, you invariably increase intra-abdominal pressure, and that reduces venous return to the heart. So for somebody who has severe cardiovascular disease that may not be able to maintain cardiac output on their own, so those who have heart failure or outflow tract obstruction or left bundle branch, but anything that can reduce cardiac output effectively or anything that can reduce venous return, you may want to think twice before doing laparoscopic surgery for such patients. So it's advised to either resuscitate them fully or consider other approaches. But by far, the complication rates for laparoscopic surgery is far less than open surgery on case-by-case basis. Maybe with the exception of something like laparoscopic cholecystectomy, which has a slightly higher complication rate compared to open when it has to do with bile duct injury. But the other added advantage far outweighs that. I mean, the person goes home the same day or at most the next day, compared to laparoscopic cholecystectomy, open cholecystectomy that will be there for about a week. All the incisions added together are not up to 2 centimeters, compared to open cholecystectomy where the person will have a subcostal incision or a midline incision that is very painful. This person rarely has pneumonia, which will be present in open cholecystectomy. And I can go on and on and on and on and on. So for the second one, I know for sure that right now there is a curriculum in Obafemi Awolowo University Hospital, Ile-Ife, for laparoscopic training for medical students. It's ongoing now and it's been championed by our mentor, Professor Adisa. And this has been done with gracious support by some of alumni of the university and himself with his collaboration with his overseas counterparts. And the good thing with this is that the simulators are even AI enabled. So as you are doing your training, the AI is giving you a feedback whether you are succeeding or not. And at the end of the day, it scores you. So this was pioneered earlier this year, and they've been shown that there have been more than 70% uptake of students who are now interested in surgery than before. Surprisingly, more females than males. I guess all the guys are going to IT, but the females now want to do surgery. So it's available in the country. So like people like us, myself and Dr. Arua, when we're in medical school, we'll read everything about management of cases, and then we'll add 2 lines, further trends or future trends, laparoscopic surgery. And they'll just tell you don't need to know about it because it's not available. That's what we're told then. And, you know, it was only by the sheer tenacity of our teacher and recognizing that some of us are actually interested in this, and we came close to him and he was encouraged that we were able to say this. So I think there has been a change. People like him started doing laparoscopy after they became consultants of many years. They now had to go and train themselves. Right now, laparoscopy is now being taught to people who are not even doctors. And currently, there's even a study going on to teach laparoscopy to non-doctors, such that even in places where doctor is very few, a doctor and a nurse or a technician can do safe laparoscopic surgery. That study is going on and is funded by the National Institute of Health Research from UK. So a lot of things are being done. And like they said, I don't know if you're a Christian, but they said that my people perish because of lack of knowledge. A lot of things are not being done or are not being known because information is not there. And that's why we have things like this colloquium, to let people know that such things are available. So I'll encourage you, if you are interested, reach out to Professor Adisa in Ife. And I don't know if you'll be around tomorrow, but there are also, we're all here too, who can help you. And I'm sure that his fulcrum or his direction now is also to replicate that same curriculum of medical students in Ife to other teaching hospitals. So thank you very much.
Thank you. So the lady, she has been raising her hand. Don't worry. We see you. Please, let's give her the opportunity. Is there any other person that I'd like to ask a question? Please also. Okay, there's one in front here. Okay.
My name is Adejare Hikmat, a 500 level medical student from College of Medicine, University of Lagos. I'm here representing the Surgical Interest Group Lagos, which is a group of students that are interested in surgery. First of all, I'd like to thank Evercare. I have been a beneficiary firsthand of the great work that Evercare is doing. This surgical colloquium, a number of things have been said, and a number of my questions have also been hit on in bits while answering questions. Several people have advocated for residents, advocated for surgeons, advocated for the exposure of surgeons generally in laparoscopic and minimally invasive surgery. But I'm happy that we have great stakeholders here from the government and from several institutions, and I'll be advocating for the students. These things that are going on in surgery, I must say that maybe before I came to Evercare as to observe my elective rotation, I didn't know so many things that were obtainable in Nigeria and in surgery generally. People are in school, students are in medical training, the basic 6-year medical training, interested in surgery, and they are kind of streamlined. In LUTH, I only know CTSU as lobectomies and random laparoscopic surgeries, not open heart surgeries and what they do in Evercare. Sincerely, I don't think anybody else does it in Nigeria. And first off, my first question is that to the stakeholders here, it would be great if medical students are put into consideration and these things that are sort of high-end are being exposed to medical students at a very early stage. Like I said earlier, I thank Evercare for giving me the opportunity to do that. And we have this elective rotation time in school where you can go and see different things. You can go several places. It would be great if the private sector medicine open up to students, because there are not so many teaching hospitals that are owned by private sector. And the big things are going on in private sector. The new things are going on in private sector. I want to be a neurologist, and I've only seen open prostatectomies done in LUTH and maybe some TURPs. My first lithotripsy was at Evercare. I wouldn't have known such things, and I am challenging the stakeholders in medicine today to involve medical students. Surgical Interest Group is a group that started in LUTH by medical students, and earlier in July we hosted a first ever conference held by students, and it hosted about 800 students from several schools in Nigeria. We thank some of our surgeons, Dr. Ifedayo, Dr. Arinzechukwu. They have our back. And this is just 2 people in the whole number of surgeons we have in Nigeria. Long and short of this is that I'm imploring the stakeholders in healthcare in Nigeria to please come closer to the students. Like, our theme for this conference last year was From Classroom to OR, nurturing the next generation of surgeons. If the next generation of surgeons don't know the great things that you're doing high up there, everybody's going to Jackpa. Sincerely, you can't stop the Jackpa. If I know that these things can be learned in Nigeria, things I want to do, things I love to practice can be done in Nigeria, it might not convince the whole number of students from leaving, but it at least gives them some avenue that you can do these things in Nigeria. You can learn these things in Nigeria, and win-win for Nigeria in the end.
Amazing.
Thank you.
So it's more like a comment than a question. So is there a question in there? Dr. Ifedayo would like to, also comment on that.
Thank you very much. Hikmat's my urologist. So I met Hikmat in December, was it? Last year, and through a mutual colleague, her lecturer, and she came to us at Evercare, and she saw what we were doing, and I'm pretty sure in a few years, maybe let's say 8 years, you'll be practicing urology, without a doubt. Now, I think what you said about collaboration and opening up to medical students as private organizations is very, very important, and that's a message that we're going to take up from here with our SLT to kind of create an easier avenue for students who want to do elective postings at our hospital to come and see what we're doing. And these things help because the more of the high-ed things you see in the areas that you are interested in, the quicker you develop your interest in those areas and improve your competencies. So it's something that we definitely have to do to encourage our students. And we have 2 big medical schools in Lagos and many others around us. So it's something that we will have to do.
Thank you very much. So, Hikmat, you've heard from Dr. Ifedayo. He's saying, please don't jackpot yet. Evercare is coming. All right, let's hear from, I know a beautiful lady was here that, okay, there's some questions online too. After you, I'll take some of the questions online.
Good afternoon, everyone. My name is Suliat Sulaiman. I represent Metronic Nigeria. My question goes to Dr. Akinola. I'm sorry if it sounds like I'm dragging you back a bit, but I'll be talking about fibroid again. So I understand that every surgery is considered risky, right? So I know, personally speaking from experience, I'm in a female support group, and in that group we lost about 3 members this year alone due to myomectomies. So I would like to understand what happened, what goes wrong in surgeries that leads to complication, that leads to loss of life during myomectomy procedures. This thing is, it's really scary. We hear it everywhere online. I understand that the rate of death is low in myomectomy, but these things are still happening. We are losing women every day due to myomectomy procedures. What is going wrong? What is happening? What are the complications that are arising and leading to loss of life? Thank you.
Okay. They've asked that question directly to you, sir.
Yeah. Okay.
What is going on?
What's going on? Well, I don't know. Let me start by saying, when I got to Lagos and I found out how people dreaded myomectomy so much, I was wondering, well, medically speaking, let me say practically, myomectomy has its inherent potential complications. But honestly, it would be good to, in the support group where you belong, to find out, number one, where are they doing their myomectomies? Because myomectomy is not just about where you are, it's not just about who is operating, where you're operating, when to operate, who to operate matters. The phase of the menstrual cycle, you can have a great surgeon. If you do your myomectomy at the proliferative phase of the menstrual cycle, where there's increased risk of blood loss, or you do not sort out certain inherent problems that can make it a risk that can actually, honestly, I do not believe you should do a myomectomy, especially the kinds we see in Africa, without plan for the post-operative period. You cannot do the type I showed you yesterday without having an ICU, an intensive care unit. Because this particular patient I operated, I put a drain in. There's an intraperitoneal drain. That's even after ensuring that there was adequate hemostasis. The purpose of that drain is to actually see, is there any holes that we have put after, things like that. Then adequate care in the post-operative period. So those things also, they matter. Then the second thing is, I'm also surprised that there are still a lot of people who still do myomectomies without putting a tourniquet. Actually, the use of Foley's catheter as a tourniquet was popularized in West Africa. You won't see it even in some textbooks about using tourniquet to reduce blood loss at surgery. This was an improvised method, started, popularized in West Africa, and that's why I say I stand to be challenged, and it's actually something I can say anywhere in the globe, that the skill for open myomectomy is in Africa. Is in Africa, because we see these very huge ones. And it's about the more you do. If I had all my undergraduate training in the Western world, where I do most of these ones through minimal asset, I may be a surgeon of 25 years. I won't be confident doing this kind of large myomas if I'm coming back to travel. So that's why also the rule of skill transfer also matters. So myomectomy may look potentially dangerous. We've done over 160, 150. We've not lost a single patient. And I've been doing myomectomies since year 2010. Okay, I've not lost a single patient due to myoma. And we've done. I'm talking about rough abdomen, dense additions, and things like that. So there are measures to. Although I'm not saying there can not be complications, because a surgeon who says he has not seen complications has actually not done enough. There are rough abdomens. There are days you go to the battleground and you know that this is going to be very rough. But you must also know when. I planned a patient for a repeat myomectomy before. I opened up, and what I saw, I knew that it was better for that patient to just have gusarelin, cancel her about choosing surrogates to have children. If I wanted to be adventurous, of course, I could call in someone like Dr. Arinze, separate additions and all those things. It wasn't just about the additions, the bowel additions. It was also about the pelvis. Because sometimes the additions are the bleeding that happens. You may put all the stitches in the world with all your Surgicel, your Surgifoam. You as a surgeon, when you close up the abdomen, you know that abdomen was not dry. You understand? So there are times a surgeon must also know when not to operate. When to say, madam, you don't need a repeat myomectomy. If you need to have this second surgery done, is an hysterectomy. It may be a painful decision. It may be safer for you to use a surrogate to carry your baby and be alive than for you, because you want to conserve a uterus, lose. So then some of our women also, I must tell you, some of our women also, we also have to speak to faith institutions, religious institutions. There are people who we have, educated people, heavy menstrual bleeding due to fibroids, that they have known. This other patient was not aware. She didn't know. She didn't have submucous fibroids, so she didn't have heavy menstrual bleeding. But some people knew. They know right from time. And they still follow use of herbal medications. I've seen a lawyer, I'm going to talk about a lawyer. I don't know whether she was hypnotized. Somebody convinced her to use an herbal pessary vaginally, that the fibroid will drop. She preferred that to surgery. Now, what happened? She inserted the herbal pessary. The herbal pessary caused acquired gynaecology, that is occlusion of the vaginal orifice, and did not solve the problem. So what happens when they deceive them that there's something they can insert vaginally is that thing causes necrosis of the vaginal wall. So what they see in Instagram or what they show them that, fibroid is dropping, it's not fibroid. I stand to be corrected. I'm waiting for that person who will come and show me evidence of something you insert vaginally and a submucosal fibroid will drop. It will not happen. It is the necrosed vaginal wall that they show people. But you see, in Africa, if you can tell people that there's a tea that you can drink and fibroid will shrink, you will make more money than the surgeon. And you would have made your money over 2-3 years. Then after 3 years, people will find out that tea is not working, but you've cashed out. Then you move to another business. No, that's what happens. So if you tell people that any other thing but surgery, they come, but is it working? Even for some of these alternatives to surgery, it's about patient selection. I do not want to mention, I've seen people go for high-intensity focus ultrasound and they come back to have their surgery done, because I look at the fact this is not going to huge intramural. There's patient selection criteria if you want to do HIFU. You okay? If you want to do HIFU, some patients will benefit from HIFU. For HIFU is high-intensity focus ultrasound, but some candidates are not candidates for HIFU. You just go, you do your HIFU. After 24 months, you still have to do surgery. So surgery is not the only option, but you must carefully select patients. And no doctor should box a patient to a corner. I shouldn't say a patient who wants to do hysteroscopic myomectomy, and because I do open, all patients must do open. That must not happen in this. We must give patients that freedom to choose, but you must guide them that this is actually what you need. So those are the things responsible for some of the calamities we have with myomectomy.
All right. Wow. Okay. So we're just going to take. Oh wow. Okay.
Oh. Once again, permit me to say something. Thank you very much, Dr. Akinola, and to the lady that asked the question. Yeah, we have so many of you in the country now trying to fight for the right of the client or your right. May I suggest that let your organization look out for some notable CSO, civil society organizations that are into campaign, advocacy, and the likes. Last week we had a strategic meeting with traditional board, the Board of Traditional Medicine. These people have been in existence before now. Unfortunately, their practice does not complement what is available. So they need to be, capacity need to be built around them. And the case in question was also the bone setters. A lot is being done. And at the end of the day, the surgeon they put at the corner of doing reconstructive surgery fails. They now take it upon the government setting that they are the one that did it. Already, the injury is already created, and they did this already done. May I suggest at this point in time that in your advocacy, let people know that Lagos State especially have made it that 10 minutes away from where you live, there's an hospital setting, be it private or government. But government is trying to say that at public level, community level, you have primary health care. And the primary health care, the head of that, the MOH there is a medical doctor who knew his capacity or her capacity. The moment he's failing in that capacity, you referred. Many of us so-called refuse to refer. But individual patients have the right. Unfortunately, their right is not good enough because a doctor that knows somebody somehow, somewhere, so try to patronize. Of recent, we saw the case at Ikorodu, where a school start liver, a secondary school start liver, is the doctor in that clinic who has been operating for over 1 year and 10 months or so. Yeah, it was on the social media. And at the end of the day, many people have gone through him in the name of operation. May I say that there are a lot of complications, as you said, but Lagos State have made it as a law by EFAMA. We have something called EFAMA. This is Health Facility and Monitoring Agency. They are the accredited authority that goes around to see. I was having a discussion with Dr. Arinzechukwu here. A lot of our so-called socialites, in the name of losing weight, that have entered into the wrong hands, as in they've lost their life in a preventable manner. These are preventable deaths, but they find themselves being a victim. So may I suggest that in the course of your engaging with the community, let them know that Lagos is frown at losing anybody. The life of that person is so important to us. At the same time, they should go to the certified. I said certified because if anything is done, you can take any of these specialists to the court of law. But for those that they are patronizing, you can't take them to anywhere. Look at the huge amount of money the lady has paid, only to come down with gangrene, and that has to be done. A lot has to be done to revive that life. So please, in your engagement, let them know. Engage with them in a very understanding manner. If possible, make it a weekly counseling, and call the experts in that area, so that when they are making an informed decision, they go to the right place and they will be treated in that course. Thank you.
Thank you very much. All right, so the final question we'll take now will be the one online for Dr. Arinzechukwu. It says, thank you for the presentation. To our general surgeon, Dr. Arinze, given the complexity of the procedures you perform, how do you approach patient education and informed consent, particularly when discussing the risks and benefits of laparoscopic versus open surgery options? Osha, please, could you help? Thank you.
Thank you very much. Very important question, and therein lies adequate patient preparation. For us at Evercare Hospital, we pride ourselves in a robust outpatient clinical setting where patients are offered the opportunity to have either inpatient consultation or virtual consultation. And our care team is also robust because we believe that every patient should make an informed decision, especially when it comes to surgeries. But I also want to stress the fact that as a surgeon, you must be transparent in whatever you are doing. And it's important that you let the patient know all that they need to know. So in part of our engagement with patients, we have what we call the patient information booklet, which is a series of written documents where some of these highfalutin and technical medical jargon are broken down to simple words that a patient can understand. And these are also done with pictorial diagrams of some of these complex surgeries in a way that the person can appreciate it, backed by documentary evidence and literature. So in surgery, the patient can compare and contrast the benefits of open surgery and the benefits of laparoscopic surgery, as well as the inherent risk. But by and large, the most important thing is to give the patient the confidence that he or she has come to the right place, to the right set of caregivers who are committed to making sure that the person has wholesome healing. In addition to that, you must make sure that the person is well prepared for surgery. Because most times, complications arise when we don't address some of the challenges that the patient may have even before the surgery is done. There are some complications that may be inevitable due to the nature of the surgery, but majority of complications arise if patients are not well prepared for surgery. So surgeries are, I would like to see surgeries as somebody who is embarking on a journey. You don't go for a 500-kilometer trip with a near empty tank. You must make sure your tanks are full, you make sure your wheels are balanced, your tires have the right gauge, and you choose the best road. You wouldn't want to go to Ikorodu and drive through the lagoon. So these are the things that we need to be done, and by and large, when such things are done, most oftentimes surgeries go on successfully. Thank you.
Thank you so much. Thank you so much. Please, can we put our hands together for all our speakers? They've been so gracious responding to all the questions. Now, in case you still have questions, our speakers are still here. You can engage them privately and ask your questions. And I'm sure, they came here for you out of their busy schedule. Out of their busy schedule, they came here for you. So I'm sure that you would have the answers that you require. And also, you can also send us a mail. I would read out the mail shortly as the course of the event goes on. Probably after this next segment, I will read out the mail for us to, if you're not yet as confident to have a one-on-one conversation, you can send in a mail. It's been a wonderful time, and a lot has happened. From the various questions and answers that we've provided, one thing is sure is that you've been engaged from the beginning of this colloquium till now. And we're gradually winding down and rounding off. And to give his remarks, sort of in closing, I'd like to invite the Chief Operating Officer of Evercare Hospital, Lekki, Eric Ocheng, to please come and give us his closing remarks of all that has happened here today. Please, a round of applause for him, please. Thank you. Thank you so much, Eric.
Thank you. Ladies and gentlemen, esteemed colleagues and distinguished guests, good afternoon. As we draw this inaugural colloquium to a close, I find myself filled with both a sense of accomplishment and profound excitement for the future of surgery in Lagos and in Nigeria. Today, we have witnessed a powerful display of clinical excellence, a celebration of extraordinary capabilities of our surgical community, and a glimpse into the cutting edge of technology that is revolutionizing patient care. First and foremost, I'd like to extend my heartfelt thanks to our keynote speaker, Dr. Jimmy Coker, whose insights have set the tone for this event. Your wealth of knowledge and experience has not only enlightened us, but has also changed us to think critically about the future of surgery in our region. We are truly grateful for your contribution. To all our speakers and patients and panelists, thank you for sharing your expertise, your experience, and your vision. Each presentation has been a testament to the incredible progress we are making in the field of surgery. The integration of data in our clinical practices is not just a trend, it is the future of healthcare. And it is heartening to see how we are already leveraging it to benefit our patients. We have witnessed clinical milestones and exceptional capabilities of our surgeons, highlighting the cutting-edge technology that is transforming patient care. You have each played a vital role in making this colloquium a resounding success. Today has not just been about celebrating our achievements. as an organization, it has been about setting the stage for the future. We have seen and heard about clinical milestones that highlight our dedication to patient well-being and the constant pursuit of improved outcomes. Surgical prowess demonstrated by our colleagues, showcasing their experience and unwavering commitment to excellence. Revolutionary technology that is pushing the boundaries of minimally invasive procedures, offering patients faster recovery and less discomfort. This colloquium has served as a catalyst, a platform for knowledge sharing and a vibrant exchange of ideas that will undoubtedly shape the future of surgery in Lagos and in the greater Nigeria. We must remember the power of collaboration in pushing the frontiers of medical knowledge, the importance of continuous learning and adaptation to the ever-evolving landscape of surgical innovation, the vital role of mentorship in nurturing the next generation of surgical leaders. This inaugural colloquium is not an endpoint, but a starting point. It is a call to action, a challenge for all of us to embrace the transformative power of technology, to champion clinical excellence, and to ensure that the benefits of advanced surgical care reach every corner of our society. Let us leave this colloquium with a renewed sense of purpose and a deep commitment to patient care. A network of colleagues who are united in the pursuit of surgical innovation. A vision for a future where surgery in Lagos and the greater Nigeria stands as a beacon of excellence on the global stage. As we leave here today, let us carry forward the insights we have gained and the inspirations we have found. Let us continue to push the boundaries of what we can achieve, and let us do this with the knowledge that we are making a real difference in the lives of our patients and the broader community. On behalf of our board of directors, the management and the staff of Evercare, Hospital Lekki, thank you for your active participation, your invaluable contribution, and your unwavering dedication to the advancement in surgical care. I look forward to the continued collaboration and groundbreaking achievements that lie ahead. Thank you.
Thank you very much. Okay, so like I said, if you have questions you want to send via mail, you can send your questions to, and even generally any observation, any comments, you want to make inquiries, you can send to info@evercare.ng. info@evercare.ng. So you can send your questions, you could send your observations, your comments, any inquiries that you have concerning any of the services Evercare offers or prefers. Thank you very much. Now at this point, in closing, like I said, Ibuka is very Gen Z, so it's very important that we mark the memories. I'd like for you to bring out your phone at this juncture, and I want you to take a picture with the person beside you. It's very important that we etch the memory. So important. So bring out your phone. Bring out your phone at this moment. You'll take a selfie picture and a selfie video. Now, for those of you that don't know what a selfie video is, let me help you. So please bring out, yeah, I can see us. Now this picture is not a picture you're going to take and put in your gallery. No, this picture is going out. It's going out on social media. Whatever social media that you are most known on, whether Facebook, Instagram, Twitter, LinkedIn, to go. Anyone that you're known on, make sure you start with someone, hashtag Evercare Hospital Lekki, hashtag Surgical Colloquium. We put it everywhere so that you'll be able to spell it easily. So, yes, take a video, take a picture. If the person beside you is not doing any of them, that person is bad vibes. So. So let's go on. Yes, and if you feel like standing from your table to go and take with somebody else, you can do that just for the next 5 minutes. You see, that's what we're talking about. Because the speakers that we have today are our superstars, and they have shown immense dedication and service to us all by being here today. So, yeah, I can see the medical students, they know what's up, they're ready on that vibe. It's time to pepper the other people. Please do take a picture at this point. We're gonna have some music in the background, you know, while this is going on. I think I myself too would like to take with people. Where's that my guy with the phone? Let me take pictures too. So that next time I come to Evercare, where's that my? There's someone I'm looking for with the phone. Let me borrow yours. Okay, let me take some pictures myself. Let me take with this very high table. Can I take one? Yes, let me take one. Let me just take one. Yes, by the time I take this picture, if I come to the reception, it's just like this, I'll be showing them all. So that well, let me take. Okay, is everybody in? Yeah, cheers, amazing. Let me take also with this table.
Communities in Lagos. Evercare Hospital Lekki is the largest private hospital in Lagos. A 165-bed, purpose-built, multi-specialty tertiary care hospital. Evercare Hospital Lekki offers high-quality and accessible healthcare across a range of specialties.
Evercare Hospital Lekki is a part of the Evercare Group, an integrated healthcare delivery platform investing in healthcare in emerging markets. Our vision at Evercare Hospital Lekki is to be the most trusted healthcare partner and preferred destination in Nigeria and the West African region, transforming the quality of healthcare and positively impacting lives across the region.
At Evercare Hospital Lekki, we are well positioned to address the gaps that exist in the Nigerian healthcare sector, and we aim to be at the forefront of advanced treatments in major clinical specialties. Our focus specialties are mother and child services, cardiac sciences, neurosciences, orthopedics, critical care and emergency medicine, amongst a range of other specialties. We have engaged a team of highly skilled and experienced full-time visiting consultants across subspecialties of medicine, surgery, pediatrics, obstetrics, and gynaecology. A collaborative team approach to care will be promoted, continuously monitoring patient-reported outcome measures for optimal patient satisfaction and quality improvement.
As a purpose-built multi-specialty tertiary care hospital, our patients will receive comprehensive care that is efficient and thorough. Our infrastructure systems and services are designed to assist our physicians to deliver world-class services to patients.
At Evercare Hospital Lekki, we believe that every individual has the right to respectful and compassionate care as a patient. And we have introduced a framework for patient experience, encouraging each caregiver to treat every patient as they would their own family. Our caregivers are passionate about providing patient-focused care, and this reflects in their attitude to the patient's overall experience at the hospital. We have been strategic in attracting the best talent locally, and complementing their skill set with international experts to ensure a highly skilled, well-rounded, and diverse team.
Technology is critical to delivering high standards of healthcare. Evercare leverages advanced technology and state-of-the-art equipment to ensure desired clinical outcomes are achieved.
We are fully equipped and technologically advanced to cater for high-risk pregnancies and even the most fragile babies. An entire floor of the hospital has been dedicated to serving women and children.
Evercare Hospital has been designed to promote seamless patient flow and positive patient experience by positioning our entire daycare services, physiotherapy, chemotherapy, endoscopy, and dialysis on one floor. Our endoscopy unit is equipped to investigate and treat the full range of pediatric and adult gastrointestinal diseases, including advanced endoscopic procedures.
At Evercare Hospital, we have a multidisciplinary team of specialists to treat a wide range of cancers, supported by friendly and relaxing chemotherapy units for patients and relatives.
Evercare Hospital Dialysis Unit is managed by a team of highly experienced dialysis nurses, technicians, and nephrologists. The unit provides a welcoming, spacious atmosphere with individual entertainment units for patients to help pass the time. Affordable quality service is provided by strict adherence to guidelines and standard operating procedures.
The physiotherapy unit at Evercare Hospital provides the most comprehensive rehabilitation program for patients, particularly those with stroke, leg injuries, and pre- and post-surgery, giving them better quality of life.
Evercare Hospital has managed to attract highly talented group of nurses practicing in a dynamic environment to provide empathetic care. Our promise is to provide high-quality nursing care in a safe and comfortable environment.
We believe every individual has the right to respectful and compassionate care as a patient. And with the largest critical bed units in a private setting in Nigeria, we are well prepared to address the critical care needs of Nigerians.
Our in-house physicians, partnerships with Nigerian doctors in the diaspora, and doctors from Evercare Group will ensure that we have the capacity to provide treatments that many Nigerians seek abroad.
Quality is at the core of Evercare Hospital Lekki's healthcare mission. A robust clinical governance process has been implemented to ensure continuous quality improvement and the adherence to international standards for ethics and compliance. At Evercare, we will constantly innovate to ensure delivery of best-in-class standards of patient safety, clinical excellence, and outstanding clinical outcomes, with an unparalleled patient experience. With our dynamic and passionate team of caregivers, we look forward to embarking on our journey to transforming lives.